This is just a talk. I want to show you these odd pictures and talk about odd skulls, and then we're going to start our anterior midline, and yes, it'll be all weird stuff from here out. A lot of common weird stuff that I do, some stuff that I don't do so much, but most of the weird stuff I do. I do it. I weave it into when people are not paying attention to me, and I don't give too much explanation to patients about my weirdities. It becomes apparent. This skull. How do you think this got this way?
Photoshop?
Shame on you. Shame. Although in the world we live in, it could be. No, this would have been made this way. Okay, they would have, this is a, I don't know whether, I forget the history on this picture, whether it's Indian or Incan or something like that, but they would have deemed that this person was going to be a lucky priest or priestess or something, and tied their head around it and caused it to grow that way. So the head has plasticity. I show this for obvious shock value starting out a lecture, but to give you the idea that if you cause the head to grow in a funny way by stricture, by in this case imposing a stricture by putting a wrapping around the head, the brain finds a way to grow. So this would have been done on purpose.
Cranial binding of the foot binding.
There's still cultures where they're still doing this.
How's that
There's
work
still
out for the
cultures.
recipient?
I'm
serious.
I couldn't tell you. Apparently, it gives you an overbite problem. But I don't know. I guess if everybody kisses your ass and now respects you because you're the cone head of the society, it's probably pretty good. But I can show you how it works out with someone with normal intelligence. I don't know how this affected the brain. I would imagine this is someone who's probably ADD or ADHD at the very least. But let's look a little further.
Looks like it'd be hard to sleep on your back.
Yeah, we got lots of material for this. We got lots of material for this one.
I think the person's name was Abby. Right?
Abby, somebody else.
Right.
You and I in a weekend in a hotel would be a dangerous couple. And given the way you turn back that beer pretty quick too. Romance starting. I took these pictures from a book. When I was an intern, I did my pediatric internship, pediatric emergency intern month. I did it at AI DuPont Children's Hospital. And when the little bit of free time I had a library, so I went down and I see if there's anything for me. I found this book on cranial synostosis that nobody had checked out since 1966. I was born in '62. And I'm thinking, I looked through the pictures, which is what I now have here for you, and I said, I can use this in lecture. I should steal this because it's been checked out in 1966. I said, then somewhere there's going to be a karmic thing for me if I steal it. And I'm telling you, I went back and forth for the whole month with this book. Should I return this or not? And I want you to know, I did return it. And I later bought it, and it was frickin' almost $300 for this book, just to scan the pictures. Had I known I'd be able to rip it all off from the web later, another story. So some of these scans didn't come out too well. You know, I'm using a scanning machine. This is a normal skull here, okay? And some of the pictures are a little bit redundant. So in the newborn, we have the anterior fontanelle, posterior fontanelle. Mona, can you see here? Okay. The idea of what we'll call normocephaly, everything's going along fine. Things can be synostotic. When they're synostotic, it's when the sutures actually obliterate. Okay, when they either grow together, there is no suture line anymore, the bones are now one thing, or they are plagiocephalic, where they can look very similar because it's very, very restricted, but the suture still is patent. There still is collagen in there, there still is everything we talked about in Cranial 1. So there's all these different deformations we'll talk about. I mixed this in with some things from Beryl Arbuckle's book on her writings I thought were interesting as well. Beryl Arbuckle was the one who was doing the work with CP Kids, presented that work in the 1940s that I gave you a few days ago. And these were her drawings trying to show lines of tension in the fascia, in the dura. And again, I think this is somebody doing this way before, you know, CST and other people were even acknowledging, well, not CST people, you are acknowledging this, but way before traditional medicine was acknowledging any of these ideas. She was trying to think, how do stresses pass through the skull? We talked about something as far as, I mentioned that guy with the Contrecoup injury. to get hit with a ball on this side of the head and not have this bone break but have the other bones break. That's a clear picture of trauma vectors. We can do a whole other day talking just about trauma vectors. So she's trying to explain skull injury, what happened during birth for these kids. These were dissections that she did, where she carved out the skull, trying to show the areas that she felt would have allowed forces to pass in and around the skull. She carved out the squamous of the skull, leaving like the petrous ridges and things like that. Does it mean anything? No. I just want to show you the work that she did. And I've seen a skull that she carved out like this. Don't have one in my possession, but I've seen it. Here's a view from above, a view from below. Again, not something to do with this information, but what she did was carved out the squamous, the flat portions of it, trying to identify sutures or how things would have aligned with each other. One more photo. That's all Earl Buckles carvings. Now back to the neurosurgical book. This is a normal skull. Some of the scanning didn't come out so well. This is all normocephaly. Just see how far back this is. This is all frontal bone. Okay, all frontal bone here. There's a coronal suture. Normal. Front, back. These rings, you can tell how old the baby is by how many rings it has around his head. And when I saw it came out like that, I tried rescanning it and whatever, and I don't know why, but we apparently have tree rings on all the skulls. So, okay, now let's get to a deformation. I happen to know these names only because, one, I talk about this every week in some place, and I've had the luxury of, particularly last 4 or 6 years of my life I spent with the Amish, and the Amish is just a preponderance of genetic problems, so I saw a lot more than the average duck might see. In my regular non-Amish practice, maybe 25% of my practice was kids, infants, babies, stuff like that, which is still a lot for most osteopaths. But with that or stuff I see around the world, when I say after class or on free days, hey, bring me all your lepers, they do bring the lepers. Okay, they bring people that look with every weird thing. So I know these names. So if you don't know these names, you never have to remember them, but I think it's kind of cool. This is a scaphocephaly. When we look at it here, it doesn't look too abnormal. You forget the bad quality of the scan. It looks kind of normal. When we look at it from the side, it's not. If this kid comes in your office, they got a pancake head. Okay? You might not see the pancake head. The scaphocephaly is probably 3 standard deviations from that bell curve from the center. But what you see in your office is 1 or 2 standard deviations of somebody that looks a little bit abnormal and the kid's symptomatic. The old ha term I gave you was the FLK. When you see the kid that looks funny looking or odd looking and their head is a little bit misshaped, probably they're symptomatic. And the simplest label that they would probably be given is ADD, ADHD. And I really can't even distinguish the differences between the two of those without going to the dictionary. They're both kids that are getting in trouble in school, not doing so well, not studying well. And if their heads are tight and you do something for them, you'll make a difference. I do have a little spiel that I give people as far as explaining why osteopathy or craniosacral technique should help somebody, a kid with a tight head. And this is how I explain it to the parents. If Doreen had a stone in your shoe and you couldn't get it out of your shoe, all day you couldn't get it out. You just kept moving around with your toe and you couldn't get it out, shaking out. It would annoy you. But you could go home and probably be reasonably normal with everyone else around you and be okay to have dinner with. A couple of days, if you couldn't fix that thing out of your shoe and you couldn't get to the shoe store, it might be less than pleasant and suboptimal to dine with you. A week later, you're throwing the shoe out. Okay, when the same thing happens to a kid that's about 8 years old, they immediately take the shoe off and immediately smack their friend in the head with it. So the younger they are, the less political they are. The satisfaction and the solution has to be immediate. So a little bit of irritation and they just start being fidgety and they probably can't pay attention as well as other kids in class. And the dramatic story that I gave you with the kid whose mother and father ended up divorcing in a whole elaborate situation. Kids don't need much to knock them off their norm. They just need a little bit to knock them off their norm. So when you see this kid, these are going to be the extreme scenarios. If we look above, aside from counting his rings, we'll see there's no suture here. It's gone. It's obliterated. Not there. This is plagiocephaly. Plagiocephaly is, the sutures are open. The suture's there. It's a this part of the coronal suture is really tight. That's what's causing him. Plagiocephaly, we learned it in medical school as a what do you call it? Trapezoid head. Okay, like a trapezoid. But really, it's going to be something that you're going to put your hands on. How are you going to know it's plagiocephaly? You're going to put it on and you're going to say, this feels like a stone, like a bowling ball. Feels tight. I don't put it on and go, well, it's this suture, it's that suture, it's that bone. I go, well, that feels really like something's not moving. Less lifeless than another head. That's my instant feeling that I have. Then I start pushing them around, I can figure out which sutures aren't moving. Okay? But there's a different quality. I interpret that quality myself as weight. When I call them my jokes with you, I did name her Concretia. She's now she's a real doctor. She's an eyeball cancer surgeon doctor that I called her Concretia when she was a medical student because she had headaches and she just felt like a bowling ball. And that lack of movement, I end up feeling like that head is heavy. And I know it's not physically heavier than another head, but what I'm used to interpreting, I don't feel it. So in this plagiocephaly, it's restricted. What I want you to notice from this one picture, because we're going to see many in about 40 minutes, I'm going to run through 2 lectures here. Is see this orbit here is pulled over? Okay, you see this on the x-ray. When you see it on the person, what you'll notice is just their face is a little off. All of our faces, if we actually start measuring things, we're going to find out that things are not level, and we're suddenly going to become less happy than we were this morning if we start measuring our eye measurements. Okay, but the ones who are really, really tight, it's really, really obvious. Like you look at it and you go, wow, that eye is really off. Okay, and parents will deal with it by covering it up with hair. A little girl that I treated last week in Japan, parents covered up with hair, and I just don't have the heart in me to ask people, hey, can I photograph your really abnormal, horrible looking child because I want to teach on it. But she looked like one of these photos that I'll show you that's quite dramatic. Once you pull the hair back, once you pull the bangs back. Okay, here's a view from the side. Again, a little hard to tell, but the suture's gone. What happens when the suture's gone is it will appear that the skull is growing in that direction because that is going to become more prominent to you. When this coronal suture is gone, they're going to look like Frankenstein. Actually, they're not Frankenstein because everything's got to grow backwards. But when things grow backwards, this becomes apparent to you. You think they have a big forehead. So it's counterintuitive to what you might think. You can stop me anytime. This is the front here. This is coronal suture. Here's a coronal suture. This is a hemicoronal synostosis. It's gone. It's obliterated. If we look inside the skull, the fossas are going to be all distorted because of it. This is the most common one that I see, trigonocephaly, and I've seen many. The most common is this. I don't know whether statistically, birth-wise, I can't give you any of those numbers. Trigonocephaly is metopic suture in 1 in 10 of us. It's still open, and the rest of us it's essentially closed. It's a question of when it closes. If it closes very early, if this suture disappears, the metopic suture between your 2 frontal bones, it comes out like this. It looks like a wedge. Okay. Okay. So you can see this has come forward here. This is trigonocephaly. Now from here, you have no problem saying that looks weird. Parents are going to cover it with hair. They'll have long bangs or something like that. You may not see it. Do you have to be symptomatic? I mean, I'm only seeing the people that come in because the parents say there's a problem. I joke with my one friend in Hong Kong because he's got a flat occiput. I mean, it's flat like that. So we just tease him, and I said, "You must have been teased as a kid." And he said, "Yeah." And he said, "I like to think of him as a highly intelligent person. He's my friend, and he's very successful in Hong Kong. He's got a flat head, so maybe they left him lay there as a baby. Who knows?" So you can probably have a lot of these deformations and be okay. We're seeing them when they come into the office because the parents have some complaint. Or in the Amish world, we are seeing them because they go, "Oh, I think it's head shape funny," and they have some idea like I can mold this like Play-Doh, And then she says, I think he's head shaped funny. And I look at Grandma and Grandpa, and they have the exact same head. No, that's what the good Lord gave you. So that's not something I can actually reshape. Yes.
How long, what amount of time do you spend on kids?
The treatment time is very brief.
Like,
It's 7-8 minutes, and the rest I'm pretending.
Yeah.
I'm redoing it to fill up time. Because if I stop 1 minute earlier, I'm going to have a problem with the Amish.
yeah.
But it doesn't take any more time at all to treat them. And with the Amish, they're bringing them in once in a blue moon. Kids, you go into a treatment, they can go a couple weeks, see them again, a couple weeks, see them again. They have to grow anyway. You do what releases you can. The brain will do a lot of the work for you. Because it's a balloon in a misshaped barrel that's blowing up. So if you blow up that balloon and the barrel is now relaxed, it'll find a better shape. You follow me? If we took a barrel that had slats in it, right, like a wine barrel has all these slats, and if the barrel got bigger and all the slats could open up evenly, it would still look like a barrel. If these two slats were stuck together, this would open up and this would come out. If you loosen this, it'll still look a little bit misshaped, but it'll get more normal as time goes on. So you don't need to bring them in 3 times a week just because they look funny. Okay, this is brachycephaly. Again, we're going to get into other pictures where it'll be more obvious, but in these photographs here, brachycephaly, this is what we call it when the whole coronal suture is obliterated. From there, hard to tell. It's actually shallow here because as the skull's growing, it can't grow forward this way because the suture won't allow it. It's growing backward. The appearance to you, and in the ones that have skin on these pictures, which you'll see, they look like Frankenstein. Pardon me?
How is it different than the other one where there are more sutures?
What other one? Trigonocephaly?
I thought it was plagiocephaly.
Plagiocephaly is more of a general term because plagiocephaly says sutures are restricted and it can be different sutures, different combinations, and we call it a parallelogram head. The neurosurgeon would call it a parallelogram head, meaning that it's like a trapezoid. Take a square and just knock it off its kilter. But they don't really get too more. Doctors would just call them funny looking, but not being too specific about it. Here the suture's obliterated. It's kind of a flat forehead, but for us, for our eyeballs, we look at it as though it's Fred Gwynn. I can see I'm the only one who like the Munster. I know John. John's my blood brother, so I know he knows. Fred Gwynn was Herman Munster. Okay. So you look at it and you're going to say, "Wow, that's really prominent." It's not prominent. It's drawing your attention because it doesn't look like other human beings. Your forehead is rounded and it comes out a little bit. If we flatten it, your head grows backward. You go, that is really prominent. It's again counterintuitive. Now, you see that baby? None of us are going to argue. Forget the eyeballs being off. This kid, most of the kids in this book, what little information there was about actual history of these kids, had Apert syndrome or some other different genetic syndromes. So forget the eyeballs. But I've seen this kid. I've seen not this kid, but I've seen this kid. Okay, with pancake head. None of us would say, we'd all go, wow, something's wrong. And I've seen an adult like this at a conference. So obviously, this person was able to be a colleague. So you can have normal, you can be normal, quasi-normal, or obviously things that we can correct. If you correct tensions, they can grow up to, the morphology can change. You can change it. But don't promise that to people. You're not changing head shape. What you're promising is to try to release tension. Okay. Now from the side, none of us would question this. This kid comes in your office. That's not normal. That's a scaphocephaly. The sagittal suture is obliterated, so it's grown straight up. Okay. So here's our normal again. The sagittal suture is gone. It's going to grow straight out at you. If part of the right sagittal suture is gone, then it's going to appear to distort the skull in this way. The middle cranial fossa is going to be very distorted, and we're going to see some examples very quickly where we'll see inside the cranium what happens to the cranial vault. Here's the trigonocephaly. This metopic suture is patent, so they're growing this, I'm calling it trigone, like a horn. Here's these are kind of redundant, I realize. This is the coronal suture being obliterated, giving them the flat head. What's wrong with this person here? Aside from the fact that they ended up in a medical slide. The lambda is apparent here. The sagittal suture is gone, but it looks kind of normal. So what would you say about that? Could you make a comment? You could comment that maybe this fusion happened just before it should have happened anyway, or it closed later. You know, by the time we're 20, 25, 26, we should be mostly grown. So this just closed a little bit early. It didn't seem to deform the head too much. Okay, here's a guy again. These are probably pictures from the 1930s, 40s, or whatever. This little guy, you can see him coming out here. These are babies that I've seen. It's a trigonocephaly. It's got this prominence coming out. Here's another one with again, they're not scanning too well. You would obviously see this baby on your table. You'd go, something's wrong with it. If you look from above here, now you can clearly see trigonocephaly.
So, they're born this way, or it just fuses really quickly?
Well, I'm seeing them either, you know, they're bringing me the baby, and the baby's, you know, 1 year old, and they look like this, so I imagine they came out like this. When they come out, it's horrible looking. It needs to be cleaned off, wiped off, should go through like the car wash, and then their head's going to be, they should be in some sort of cone head. You don't know what it's going to be until a couple weeks later. But I've seen them bring them in my office, 1 year old, 2 year old, 3 year old, just like this. And getting all that history, birth history, you know, I asked them, but it's irrelevant. It's completely irrelevant for how I'm going to proceed forward. Did you have a difficult birth? Did you do this? You know, where'd you go for vacation? It's all the same. It really is. I do it because people expect me to do it. But it's not going to be at all useful for me. If I don't do it, they think I'm not doing my job. Yes?
So if you worked on a baby that had a birth trauma at 2-3 weeks, could you prevent this from happening?
You can change immediately. I've had people bring me a baby that's weeks old with overriding parietals, looking like an alien. And you just go through and you do some lifting, parietal lifting, and most of that, they're going to leave the office like that. And then they think that you are queen of the world in that one session, because everything is so mobile. I'm not pulling, I'm just doing the same things very lightly. You can take that overriding thing and fix it. The rest of the growth has to happen over time. This person's not going to change in this treatment session on this table, but they might grow up and a few years from now not have that trigonocephaly at all, or between months not have that trigonocephaly at all, because they're going to grow a lot. Once they're an adult and they're shaped this way, that shape's not going to change. I say kid, but he was in his 30s with spina bifida. That shouldn't have lived. The doctor said he wouldn't live to be 10 years old. I treated him in his 30s, and he looked like you took the head and went like this, like an S through his face. Okay, and I couldn't change the face. His mother and I worked at the same hospital. She was an ICU nurse. I treated her for back pain and treated her husband, and then after a year or two, she asked me to treat her son because he was having complaints of pain. She didn't trust me enough when I was a young doctor. I don't blame her. So I looked at his head, it was like this. I'm not going to change that. Let me see if I can help him with it. He is retarded because of his condition, but he could communicate, say back hurts, neck hurts. I treated him for that, guess what? His seizures stopped. He was on ceiling levels of Depakote, he was on maximum levels of Depakote, and still having grand mal seizures every week, at least having one. She goes, he hasn't had a seizure now since you've been treating him. Unintended consequence of treating skull tension.
See, what did you say the name of this book was that you...
I can give it to you when actually, no, it's in storage. It's in storage, but if you look up cranial synostosis, you'll find, it's a neurosurgical textbook. I'll be happy to give you the title, but it's in storage.
Okay.
It's not with me in Thailand.
Simply you're using Parietalist and other things. You're just going through the
I'm going around the vault. I'm doing what we did in Cranial 1.
Okay.
And some of what we're doing in Cranial, some of what we're doing this weekend, but I can't underscore enough, if you're not going around the vault, I don't know what you're going to do. Okay, what happened to this person?
bullet in the head?
Well, that would be what you might think.
Front
Oh,
on
it was
bottom.
neurosurgery.
This is from, and there's a group of people that have tried to get neurosurgeons to do this to themselves.
Oh, to take out a piece of the
Called-
body and like.
called self-trephination. If you'd like to free your sixth chakra, which we're going to work on chakras today, and we'll try and free your sixth chakra, but not this approach actually. My license doesn't
Outside of our
currently
scope.
cover me carving into people's skulls, but people will try and carve in here and carve out here. So this person did this to themselves. I showed you this video. I know I showed you in cranial once. I'm not going to show you again, but this was a trigonocephaly boy that I treated, Jisun, and I did have these pictures from his parents, and he looked much like this, or a little bit more pronounced like this when I first started treating him. I showed you in cranial one two baby videos, right?
Yeah.
Yeah. So this was the boy Jisun here, and okay. So this was later on, and of course. This is the last of the days where you had to take the picture and then develop it and see what came out. So you really can't tell Jack from this picture, but it's pretty well flattened, and I had showed you a video of him moving around doing whatever he's doing. This is another one. I don't take pictures of people and say, I feel too bad for them for what's already going on with their family to take pictures. This was a boy who came into my office, and the mom had this old picture of him. He was a trigonocephaly. She brought him into the office as a baby. And this was the after. Again, it was with a photograph, and it's not too clear, but this was a few treatments, and it was completely gone. And she used to send me, I would get Christmas cards on up until about age 7 or 8, very normal kid. She'd send me Christmas cards every year. His name is Oliver. And I will tell you the story of Oliver. She brought the baby to me, and she said, I want you to treat my son. And he's got this problem. I don't know how they found me. And she said, he's having seizures, multiple seizures all the time, every day. And he's having rhizostomus. That's what you get from Clostridium. You get like this. He would do. If you get, you step on a rusty nail, well, you get a tetanus shot. You get this. You get this opisthotonus, and he had some opisthotonus. And these just weird seizures happening all the time. And she goes, we took him to Johns Hopkins, and they wanted to put him inpatient. We didn't agree with it. And this went back and forth. And she said, so they were going to take the baby from this family, from them, if they weren't going to surrender the baby for treatment. And so we're here at your office. And I said, so there's like a cops looking for you, that kind of thing? And she's like, well, yeah. And I said, okay, that part, I didn't even hear what you just said. So this is Oliver, he's got a problem. I'm going to treat Oliver. I said, I didn't hear anything what you said to me before. And she said, oh, and this is the other unique thing she said to me. Here's the husband here. She goes, this is his husband. He's kind of slow. He's a bit slow. And he was slow. If somebody calls you slow and you don't even make a comment about it. If your wife introduces you as my husband Steve, and he's kind of slow, and you just sit there and cheer it like that, you in fact are slow. So I said, so you went to Johns Hopkins, why didn't you go there to see that? She said, because they wanted to do all these drugs on him and do these things, and we don't believe in that, blah, blah, blah. And she said, then they wanted to take the baby from us, and so we left. And we're on the land. And I said, I don't know any of that, and I don't want to hear any of it. You're here in the office, I'm going to treat you, but I don't know it. So I treated him, blah, blah, blah. A couple of treatments, happy story, it's resolved. Seizure's gone, rhizostomus gone, opisthotonus gone. Steve Sennett, miracle worker. Okay? And then when I forgot all about it, like a couple weeks later, or whatever, I get a call. This is when I had a receptionist and I had a regular medical office. My receptionist goes, Dr. So-and-so, from, calling from Johns Hopkins, and I'm like, or not from Johns Hopkins, calling from Maryland or something like that, which is where Johns Hopkins is. I'm like, I don't know who that is. I'm always creepy when I don't know who it is on the phone, what you could possibly want from me. So I go, I don't know who that is. I go, what is it? And my receptionist goes, well, it's about Oliver Tessar. And I go, and I'm a bad liar. So I pick up the phone and I go, I pick up the phone. Hello. This is Dr. So-and-so. I'm a pediatric neurologist down at such and such. And I go, yeah. Did you see Oliver Tessar? Oliver. Let me see if I saw him. I saw him like a few weeks ago, and then the whole case, I remember it because she told me they were on the lam. And I said, Oliver, yeah, I think I saw it on Oliver, yeah. She said, what'd you do? Oh, what'd I do? Oh, just some really light. I'm thinking Oliver's dead in a ditch somewhere. Some really light cranial stuff, just kind of touching him. Well, I want to know what you did, because I'm seeing him now, and I got a lot of patients to send you. It wasn't the same doctor, because I told her after it was done, and he didn't have the seizures, he didn't have the episiotomus, he didn't have the rhizosmus. What should I do? I said, I'm really glad we had a good result here. I said, but I really think you need to have a pediatric neurologist. If you see any symptoms again, or if you don't, I said, you should have somebody on the team. I said, if you're afraid to go there, go to another doctor. Just go to somebody else. I said, they're not going to take your baby away from you when they're normal now. Maybe they would now, but they can't reclaim a normal child from you. So she went and saw another person. That's who called me. That was really kind of funny. And she sent me a card every year. So that was Oliver. He still had a little bump here when I took the picture, but all his symptoms were gone. So, I got plenty of stories where nothing happened, exactly zero. But in the traditional medical world, they really got nothing for it, and they don't really consider it to be too problematic. I'm not looking to impose wellness on people that are not having symptoms. But if they're bringing kids to you that are fidgety, common complaint. He doesn't study well, she's not paying attention. Well, maybe they're just in that area of the bell curve, or maybe there really is something we can do for them. So they can have a plagiocephaly, and it can be because it's deformed, or because it's the sutures are actually closed. Now let's look at some cutaways on the inside. If we take this hemicoronal synostosis, this part of the coronal suture is obliterated here, and you're going to have distortion in these posterior, middle, anterior cranial fossas. What's important about the distortion is these barriers are going to actually start to squash gyri. So they got reasons why maybe the brain isn't functioning the way it should. Okay, the brain is something that's a basketball floating in fluid, surrounded by a jar. And if the jar is too tight, they're going to have symptoms. What's wrong with this, aside from the massive hole in the head? Wow. Should that be there? It's kind of a tricky question. You wouldn't really know without all of the information. That's the anterior fontanelle. Why is it all deviated? Because there's no coronal suture on that side. So it can only be on that side. So it forces the bones to grow along the other way.
That little spot on the right, is that the frontal bone, that tiny little thing?
Yep,
Yeah.
yep. And you can see the orbit here is being dragged over. Here's a child who died from having a straw put through their head. The straw is just to show you the deformation. What kind of deformation is going to happen if the coronal suture is partly closed. Here's the lambdoidal suture here, closed partly early. Here's plagiocephaly. None of the sutures are actually closed. This is a normal head, just a roentgenogram. I just think it's kind of a cool picture. Again, I scanned everything, so I said I'm never picking up this book again. So normal skull, here's sagittal suture. Sagittal suture closed is going to be that pancake head, thin pancake head, and this is coronal suture head. But the frontal bone will appear to be coming out at you, but it's actually quite flat. And then some other permutations that can happen. Scaphocephaly, if this is gone, the skull's going to grow in an elongated fashion between the frontal and the occipital, and it's going to go straight up at you because the parietal bones are not allowing it to separate. Brachycephaly, if this is gone, our growth has to happen here and here. Okay, what's wrong here? What would you make a guess at? Well, the posterior cranial fossas are huge, and they're huge on both sides, and they're kind of equal. So if you had to make a guess at, the lambdoidal sutures are closed. When did they close, if you had to make a guess?
Early.
Not too early, because the foramen magnum is still kind of round. This person might have, we could make a further guess, that maybe they have Arnold-Chiari malformation. Arnold-Chiari malformation is when the foramen magnum is a little bit larger. And when it's a little bit larger, there's slight herniation of the brain. About 15 years ago, there's a big kick on in medicine to say that people that have fibromyalgia, it's because they have Arnold-Chiari malformation. There was a lot written about it. And I think that's kind of ridiculous, but anyway.
With that, do you have to be, I mean, how can you tell that they would have that? Like,
You wouldn't. You wouldn't. At them on your table, I wouldn't. I can tell now because I'm looking at this picture. If they're on my table, I'd go, well, that's a stone head. Okay, and I'm gonna feel that this doesn't move well because they don't have sutures here. So you're gonna go, well, your occipit's really restricted. You're gonna work on them a lot. If it's an adult and it's closed, it's gonna stay closed. And it's never gonna, tissues around it are gonna loosen, but you're never gonna open up the lambdoidal suture because it's not there. This will feel normal to you.
and if they have a herniation, you can feel that though?
No,
No.
I can't. I don't know a way to tell that. When I say herniation, hernia means when something is where it's not supposed to be. So you get a hernia in your muscles, in your groin, you herniate a disc, it squashes out where it's not supposed to be. Hernia is the brain starting to drop down where it's not supposed to be.
But
If the brain is herniating, I wouldn't be able to tell it.
dangerous for an AO release?
I would think it would be dangerous for AO release, but this person's complaints, I'm probably not looking to whack and crack their neck anyway. But if this is an adult walking around, here's the thing with high velocity thrusting. First of all, I do high velocity, really low amplitude, and I'm a pretty light guy. I'm on the light side. One of my friends I went to school with was a chiropractor before osteopathic school, and he helped me a lot with learning HVLA. And he would say to me, Steve, I can crack a tree. And I said, and that's very good for you that you can crack a tree, Maurice. I have no interest in doing things that hard. When I do mobilize things, if I feel I want to do it and I do a little bit of it, I go, bang. If I didn't get it, I might try it again, and then I'm done. So for me, I'm not doing a lot of that anyway, but would this be dangerous to do OA release or AA really hard? If we're going to compare the mobilizations that are going to happen today to all the people, if we're going to compare all the bad results from a mobilization today that are going to happen compared with all of the drugs that are going to be given today, there is no comparison. You can't even compare all the high velocity things that are going to happen today. So that's kind of a, doesn't make, the chiropractors get an unfair bad rap about that. But having said that, no, I'm not looking to whack and crack them. I'm not going to know this. If they had a big herniation, they're suffering from what's called death. Okay, because actually, if the brain herniates down, what happens is the medulla is going to hit this, and that's your respiratory centers and your cardiac centers. So you get uncal herniation, and the uncus of the brain is another little knob over here, and you're gone. Anyway, so these things we can look at it after the fact because we're looking at this cool picture.
And they can't do a suspension of the brainstem like they would a bladder or something like that, pull it back up.
You got me, John. You got me. I couldn't tell you whatever the current things that they're doing.
There's a certain number of people that don't have DENS either, so doing lifting up into the AO or whatever and going right to the spinal cord so you don't have that piece.
My answer is just, you make so it's always going to be better to make an error on the side of safety. Anybody that I'm mobilizing anyway, I've done other things too in my practice, not sit down, how are you, nice to meet you. That's just not my style. So I have a million steps along the way. How about this guy? What do you think's wrong with this person? Looks kind of normal, aside from the big dot on the top of his head. Like horseshoes right here. These sutures, and you wouldn't know this. I only have, I'm reading it to you because I already know the history from the book. But this person, all the sutures are closed. They're all gone. But it looks kind of normal, right? The eyes aren't drawn up at all. So that would tell you what it was happening close to late in life when they were going to close anyway, because he looks quasi-normal. Okay, here. Now this would have happened early in life, but obviously this person survived until adult life with this foramen magnum. So if you look at the posterior cranial fossas, they're huge. It tells you the lambdoidal sutures on both sides would have to be obliterated. And this weird deformation of the foramen magnum would absolutely cause a little bit of herniation. If this person was, if they went to the MD, they would tell them they have some level of Arnold-Chiari malformation. If they have musculoskeletal complaints, as I said 15 years ago in medicine, there's a big push for saying that's the association. They would tell them you have fibromyalgia because you have this big foramen magnum, live with it. The reality is that may not be causing any of their problems at all. These are some other things, and I said I overscanned when I made this lecture just to put them together. When parents have these kids that have these horrible shaped heads, they will cover it up with hair. This is for the neurosurgeons here. They're trying to even things up for phenotype, you know, and make them look a little bit more normal. A few more here. Big posterior cranial fossa and a little bit wider on this side. So probably, I forget the history on this one, but this would be both lambdoidal sutures and this left hemicoronal suture here. This child I've seen many times in my office. Not this child. These pictures are from the 30s, 40s, or 50s when I was like that. But this kid, bug eyes. You look at the eyes and you go, "That's not right." Whatever it is. Any Seinfeld fans in the room? Remember the Ugly Baby episode?
Yeah.
They never showed you what the baby looked like. Just they go, "Look at the beautiful baby." And everybody looks in the carriage and goes like this, except breathtaking. Except Elaine's boyfriend, who had told her she was breathtaking, and then later he looks at the ugly baby and he goes, "Breathtaking," and then she's wondering, what does it mean? This is the ugly baby right here. Okay, you look at it. You know, Kramer backs up this way. So I'm not treating morphology. I'm not going to tell them, "Hey, we're going to shape this like a piece of clay." But what would the complaints be that the parents are bringing the baby to you for? Forget the Amish world. The Amish are bringing it and saying, "Shape the baby's head." What's an English normal person bringing the baby for? The baby is what? Baby's irritable. Baby's not sleeping well. Baby's up all night. Baby's cranky. Okay, I'll go back to the earlier example. If I put a stone in your shoe, you can't get out of your shoe, you're going to become irritable. The younger you are, the less political you are. The less political you are, the more the baby's going to be cranky, not feeding well. Yes?
So, just to backtrack a little, if you have an ADD kid or ADHD kid, whatever they're on that spectrum, who's filled with hate, is there a
Filled with hate. I like it.
You know, those kids who come in and if they've had a weapon, we were talking about one the other day, but is there, besides doing the whole thing, is there a particular area you would focus on?
No, not for me. You know, I have colleagues that are going to tell you this equals that and that equals that, and I really don't know how to get there from here. Because I've had the demon spawn come in my office and heard the background music, Latin playing backwards. As I told you, the one child would come in, knock my stuff all over the table, poke a finger in your eye, scratch, and you'd swear, you know, he was possessed. And then he went from that to speaking. So, I don't know. But, you know, there's a lot of good people. Viola Fryman, who I think she's a wonderful person in our profession, she'll tell you all seizures are left temporal lobe. That's where the problem is. But I find that cookbook doesn't work for me. I've had seizures people that have had seizures where the problem's been frontal, it's been somewhere else, it's been somewhere else. And if you go around the vault and you do, and that's what we did in the, you know, Credo 1. Hold on one second. If you go around the vault and you do some releases, I found that I've been able to get them off their seizure medicines. A lot of times, not all the times. Yes?
I see a woman who's had, she's been hit by a car and she's had surgery, and so she has spaces in her head from where they drilled in.
Yep.
And then a lot of instability in the neck because a third of her clavicle is gone and all this, and she has seizures. So, is that dangerous to work on somebody like that who's got so much instability?
To do cranial? No. You want to mobilize her? Probably not one of your best choices. I mean, these people are walking and talking. They're walking into your office. You know, they're picking up bags of groceries. They're doing things. They're living life. So it's not like you're going to blow a stiff wind on them and they're going to die. If they are, then divinely it was their time to die. Okay, but so that you're not going to be responsible or hurry up their time to die, I wouldn't think about, you know, mobilizing them. You have so many other choices of other things to do.
But you would do cranial?
Yeah, absolutely. I can't think of a reason why I wouldn't do it. The only time I haven't done it is when, and for me as a physician, it's been medical legal. You know, two cases jump to mind. One was a girl, she was 18, 19-ish, something like that, and she was what do you call it when you ride horses? I don't know. Okay, she rides horses. Equestrian. Okay, and very, very rich family. And one of these jumps didn't go so well, and she had this bad palsy. She'd come in here with this, and it had been that way already for a few years. The mother brought her in and said, "I want you to work on her." Father called my office and said, "Don't you touch my daughter." Okay, and the father, who owns half of the globe, said, "Don't touch my daughter." He said, I don't do domestic. My own domestic cost me a lot of money, so I don't do other people's domestic. Okay, and the other one was I had a gentleman walk in my office that a friend of mine sent me to, a family doctor sent me to with a 1.5 or 2 centimeter dissecting aortic aneurysm. And I really felt bad for the guy. And he was having headaches, and I really wanted to do cranial. Cranial books would say, you know, give him all these contraindications, but cranial, if holding your head is going to make you spontaneously catch fire and die, I don't know what else can be done for you. And I would have treated him. But in the medical legal world, I've never seen a dissecting aneurysm alive. You see it post-mortem. That's what Lucille Ball died of. It's what Jack Ritter died of. You all know what an aneurysm is, right? A dissecting aneurysm is, just for a moment, is you have the tunica adventitia, a muscularis, and then an internus. When that aneurysm starts, it's like the layers of the straw. A bubble gets between the layers, and it rapidly goes all the way up through the straw.
Wow.
So the way that dissects almost always is, you know, I don't feel too, and then they hit the ground dead. This guy walked into my office. Something had dissected 1.5 centimeters and stopped. So no one's going to touch him, and he's on borrowed time. Everyone knows it. Surgeon won't operate. No, he won't survive getting the anesthesia. So I said I can't help you because he will die, and unfortunately in the medical legal world, he will die. I will have touched him, and then someone's looking for $1.2 million from my malpractice insurance. Not him, but his Aunt Tilly and 1,000 million people that are related, and that's what I've seen happen to my friends. So you have to practice with someone else. Okay, we digress.
But outside of that, contraindications, not so much.
If you read a cranial book, they'll tell you don't do cranial on people with increased intracranial pressure. I have patients coming in with shunts in their head, and I'm doing it. The shunt was in their head, they lay on pillows, they pick up bags of groceries, they move around. What I'm doing is far less tension than that. But then again, it's my license that I'm deciding to put on the line. Never been sued, never been sued medically. Had a builder that had a problem with, but medically never had a problem. And never had a professional complaint against me. I'd like to think that everybody that left, had a great result. No, some people left and didn't like what I did, didn't come back. But I'm doing it. Okay, this guy here, forget the teleorbitism. The eyeball's going like this. This is because, actually it's not teleorbitism, it's exophthalmos. The bug eye is going outwards. That's because of his underlying genetic condition. And the jaw, that's because of his condition. That flat head, just picture a little bit more milder version of that. That's what you see in your office. That's what comes in and says, well, he's not doing so well in school. She's not doing her homework. She doesn't listen to me. What's wrong with this person? It's a trick question. Nothing wrong with her. The bug eyes is because she's got hyperthyroidism. Yeah. Okay, just some more scans here. If it's going to be deviated on the outside, it's going to be deviated on the inside. The spaces for the fontanelles where the gyri are, they're going to be compressed. And the function can be normal, it might not be normal. Just an artist drawing of a trigonocephaly. There I did. Trigonocephaly with a big metal object sticking in the head. I did a lecture in Egypt and I actually had a neurosurgeon, an Egyptian neurosurgeon attended the lecture. And I asked him about that whole, who here had somebody work with Ripley's? Ripley's, believe it or not. Yeah, and I asked him about that Ripley's case, Phineas Gage.
Yeah.
Phineas Gage is the rail worker who got the spike through his head and apparently just had a bad temper afterwards, and blindness because the railroad spike went. I said, have you ever seen that? He sent me a photo. He sent me a photo of someone that was talking to him and they had like something going through their head similar case. These names, I wouldn't know these except for I'm just putting them in here for a little bit of fun in the lecture. If the coronal suture if the sagittal suture is just partly restricted and partly on the coronal suture, it gives this odd shape called a bathyrocephaly. I've never seen it. If I did, what would I do? The same thing I do. Go around the vault, look for something intraoral, do something myofascial. I may or may not have a history like this and know it. Golf tee deformity, I guess is why you know why this got named this way. Doctors are at the golf course. By the way, I've never had an interest in golf personally, but this is restricted here and restricted here, so it's giving him this knob. I've not seen that. This I have seen. I've seen 2 adult cases that have had this occipital knob where it hasn't been fascial. Again, in an adult, have I changed that? No. If you tell me you have this weird genetic problem that you're born with, my answer is, well, why are you here? What's bothering you? I have a headache. I can't do this. I can't do that. That's the problem list I want to go down and try and see if what I do makes a difference. This is a bit extreme, but I've seen cases like this. Coronal suture is partly restricted. Left side, right side. Which side? Left side, right side.
Right.
It's the right side. It's the right side. A lot of people will answer me the left side to look at that closed eye. But if you look at the x-ray under this, you'll see that this eye is actually being dragged up. Here's another one with an obliterated lambdal suture. This kid, not so uncommon. This is a trigonocephaly. This girl, the girl I saw in Japan last week, she could be the same picture as this girl.
She's Japanese.
No.
Oh.
No, I said I don't think. I don't,
It's really wrong.
well, a little early to start drinking, I think, John. But no, the girl I saw in Japan last week could be the same photographs as what you're about to see, and she's able to talk to me, and she's quite normal appearing. But what do you think's wrong with her head? What would you call it? I don't know. Let's take an X-ray. I'm not too sure about that. Let's take a side view. There you go. That's what the parents will do. They'll cover it up with hair. Let's take an X-ray from the side. Ouch! Cone head. Cone head. Girl I saw in Japan last week, same cone. And she's able to talk, sweet little girl. Got some complaints of headache occasionally. So when I'm in Japan, I treat her. And the hair is trying to cover it up. That's an oxycephaly. It's when the sagittal suture and the coronal suture are both obliterated, you're going to be bell dark. For those of you who are Saturday Night Live fans. For those of you who are not, I weep for you. This kid here, this kid has teleorbitism. The eyes are far apart. Probably one of his eyes is blind because if you don't have, if you don't see one object, the occiput will shut down one lobe. But what would you say here? Looks like a really broad forehead. That's that brachiocephaly. This kid also has to be blind in one eye. I don't know the rest of the history because it came from this book, but eyes that far apart, you can't. One of those eyes is the non-dominant eye is shut down. You can look at the eyes; they're not level at all. This is the side. This kid, you've seen this kid. You've seen it, or you're seeing them coming in your office. If you want to see if they got a curve going through their face, you see it when you're holding their head, looking down the runway. I had a couple students in my office just many years ago, and I never noticed my mother because she's my mom. And on the rare, infrequent occasions, when my mom came in and asked me to do something, I'm having to be working on her head, and I'm holding her head, and I just noticed this. You can see she's got a little scoliosis going down her face. So I had 2 students with me, and I said, "Here, come here. I want you to look at my mom like this," and I'm explaining it. And then when I'm done, my mom goes, "Come here." So in the back room, she goes, "Don't you ever do that again in front of other people. Do you know how self-confident?" I'm like, holy shit, I don't know. She's my mom. I never looked at her in that way because she's got this curve down her face, and apparently she knows she's got a curve down her face. So, you know, you'll get that picture. If you see this curve going down their face like this, and their nose is going straight out, they've had a nose job. Okay? And my mom, subsequently, got a nose job. She had a thing that was bothering her in her nose. So, you know, I got a whole drubbing about that. But anyway, this kid, you can see the nose is off, the eyes aren't level at all. If there's a complaint, what I'm saying is, at this age, maybe you do or don't change the shape of what that adult head will look like, because they're not done growing yet. Maybe you do or don't change it, but you do have a fair shot at changing the symptomatology. And the MD world, not poo-pooing the MD world, except that they are just smashing it with drugs, just smearing drugs all over the place. And that's going to mess them up. That's going to mess them up. Here, almost done here. Eyes, just not level. If you peel away the hair, you know, look at the x-ray here. If you lay them down this way, no question, look at that. Look at the skull. But you don't need the x-ray, you're going to feel it on your hands. To you, it's going to feel abnormal. How do you know what abnormal is going to feel like? If you felt enough normal, you'll feel abnormal.
Whoa.
What's wrong with this skull? What's wrong with this skull?
Lambdoid reversus.
Trick question. It's not human. That's right. I'm just doing to you what's been done to me. Trick question, not human.
Coyote.
We had a thing, and we learned X-rays in school, and they would torture us. There were classes like 250 people in the school, and so you wouldn't cut class. He would put up your picture like Steve Sannett. It comes up huge, and then a picture of an X-ray. So if you weren't in class, you know your ass was grass. So he put up the X-ray and then your picture, so you never knew when you were getting called on. And this same doctor, I saw him doing a postgraduate thing that I wasn't going to get tortured on for ER physicians, and I sat in on it when I was a resident. And he put up an X-ray of, you could see the vertebrae, like you could see the cervical vertebrae in the skull, vertebrae, 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 large space, vertebrae, vertebrae, vertebrae. And he said, what's the diagnosis? Now these were ER docs in this postgraduate thing. And he said, what's the diagnosis? And people gave all these answers, and I was a resident, so I'm like, oh, these people are really smart, this is cool. And they were all wrong. It was someone who was decapitated. So here was C4, large space, and here was C3. They were all giving answers as to what that space was. And he said, and the take-home point was, you can't know what the X-ray was without the history. Without the history, the person's head had been shocked like this, and they were decorticate. So I forget what this is, a monkey skull. But your answers were very good. And last, this was my reason for, as I said, I almost stole the book. Didn't quite. I did buy my own copy of the book. But this just motivated me to be able to want to share this information. This kid has all the sutures are fused. They tried to give him a little bit of a coronal suture by artificially opening up something here. He has some underlying genetic condition, which is what this whole book was, this neurosurgical book. Kleeblatt-Schladel is cloverleaf skull, is what they call it. And you can see the parents are trying to do something with the hair. So, I don't know, face all these impossible situations, you just try. Don't assume that the people that went before you exhausted all possibilities, because I can tell you in medicine, the worst things that I've seen in medicine haven't been because doctors are dumb, really. It's because people are lazy. And when John was here, John Metzler, one of the few times ago, John came, he knows the statistics better than I do as far as, he and I had this, because he works for a university. You have this condition and you go to the next doctor. You say, I'm getting a second opinion from Dr. A gave me this and now I'm going to Dr. B. Very often Dr. B takes that information and doesn't spend a lot of time trying to prove how Dr. A is wrong. It's much easier to prove how Dr. A might be right. And particularly with odd-looking things that medicine really doesn't know what to do with, disabled children, they go, well, yeah, Joe sort of found that he has ADD. I kind of agree with that. Maybe we don't use that same medicine, we do something else. So I never minded to have the extreme cases because no one else is really looking at what to do. The only thing I do is if I fail, I'm in good company. I'm in good company with everyone else who's gone before me. And if I do something that works out right, like little Oliver, you know, I look like a hero. So I don't, you know, I look like a hero sometimes and I look like everyone else a lot of times, but I try. Any questions?
So it's normal for most adults to have a fusion at later in life?
It's normal for most of Well, no. If we look at your skull now, there's a collagenous river, but there's a point at which it stops growing. And if it comes together and actually fuses before it should have stopped, you're going to look a little odd. And if it happens to you early, you're going to look a lot odd. But you know, even now, you'd have to look at the MD way of looking at things. Even now, people say, well, the skull's fused, but if we do a cross-section of your skull, which would feel quite unpleasant to you, there's collagen going in between there, so it's allowing some movement.
So post-stroke, can it fuse?
Pardon me?
If someone has a stroke and they're elderly, does it tend to?
I don't know to say that a stroke is causing a fusion. So I don't know how to say that you're right or you're wrong. But generally speaking, a stroke is bad. I worked on a lot of stroke patients. I had one patient that got a return of some function that was quite dramatic. and then she gave credit to her Nikken mattress that she had bought for $5. I'm not kidding you. I'm not kidding you. I worked on a woman who had a major stroke, couldn't use her arm. I treated her once or twice, and then she was able to use her arm again. She said, I think it's the mattress I bought. I'm like,
You didn't
What-
charge enough.
whatever.
If you've been 10 grand.
I don't know. Yeah, that was my mistake.
Oh.
You know, you can't account for people being nuts. I had a boy with skull problems, and also some other psychological issues, some retardation issues. But a boy who I was able to help and get him. I was able to help him from the seizures he was having, but because his mother was with I'll just say it, she just did Barbara Brennan's training, and I think this made her a little goofy. So I said, do not take him off his seizure medicines. They need to be weaned down. The way neuroleptics work is your body becomes dependent on them. If I pull it out from you, you're now going to have seizures. So this boy was having seizures, and she was a very nice lady, by the way. She wasn't crazy, but she was desperate. So, you know, she went and did 4 years with Barbara Brennan's training and so on. I'd say, look, I need to see Evangelion next week. Then she'd go to my receptionist.
Muscle test.
I'm getting Thursday. My receptionist goes, what the hell is she doing? And I go, I don't know, it's something. She'd say, my people are telling me Thursday. I'm like, I don't know, I need to see Evangelion next week. And so as I got him doing better and off seizure medicine, she would he doesn't need medicine today, and not give medicine. And then so he would seize, fall, and smash all his teeth out, scars all over his body. Put him on horses to go horse riding, he'd fall off the horse. The kid has a pile of injuries because the mother gives him medicine today, doesn't give it to him tomorrow. You know, you're just working with whatever you got. And I can't tell her that I think she shouldn't be doing this with the medicine, because then someone else is telling them their psychic prediction or whatever. So I just try and work in whatever capacity I am. I did give her all the cautions. I said that medicines do not work this way, and she did what she did. Can't fight crazy. Crazy always wins. Yes.
In the pictures of the children where the sutures had fused, it looks different. Like, it looks like they really disappeared.
They did. Yeah, they're gone.
Pictures of adults.
Yeah, they're gone. These qualities, you know, this is an old neurosurgical book, but they're gone. If you look at the skull, it'll be smooth, gone, no remnant of it. Let's take a little break and then we'll start the anterior midline stuff. Anterior midline. All right, I got to give you some preface for what we're going to be doing, and then we have quite a bit of techniques to do. Still need the gloves, but not too bad. You've done the worst. The worst was going behind that perpendicular plate. That was the worst. These ideas, this is a reduction of what I've learned from Elliot Blackman. So this comes from Fulford, and then comes from Sutherland into Fulford, transmutated, because Fulford was a different kind of guy. And Elliot was a student of his, I was a student of Elliot's. And I'm trying to put it in words what I got from him. So these are ideas of anterior midline and biodynamic stuff. That's where it's coming from. This cartoon for me sums up a lot of how I feel about science. I'm going to try and give you a scientific background for what we're going to do and what we're going to palpate energetically. This cartoon, there's some computations here, and they conclude something here, and it says in the middle, then a miracle occurs. And he says, I think you should be more explicit here in step 2. That's been a lot of osteopathy for me. This happens here because somebody said something. Or when Ray was asking me about axes and things, so-and-so says the axis is here. If I trace this all the way back to the chicken or the egg, it's really people just making a guess about something. Are you raising your hand or are you drawing your nails?
Sorry, no.
Okay. I mean, you can do that. Do what you need to do. Follow your bliss. So let's just talk about some scientific ideas first for just a moment. Before we get to the tables. Everybody should be familiar with this. You learned this all on whatever science you did. Niels Bohr, how the atom works. You have a proton, electron, a neutron. There's some usefulness of these models, and there's usefulness of the cranial models, and that is, it explains our world, right? Thousands of years ago, Greeks, Romans watched the sun come up, and they had their explanation for, you know, God Apollo or whoever lifting up the sun, and that's why the sun comes up. Then later we know it's not Apollo lifting the sun up. We know it's Pat Cassidy that's causing the sun to come up in the morning. So, our theories evolve, but we all experience the same thing. The sun comes up in the morning. With regard to metaphysical and physical things, these theories that seem kind of obtuse for us, not really useful in our world, what does it mean? Well, we build all our appliances based on this. With all the cool stuff that we have, Apple, iPhones and internet and MRIs, it comes because someone believes in these theories. This explains our big world, the atom. When we learned in science, we learned about, you probably did something like this, about single slit and double slit diffraction to explain light particles. Don't worry, I'm not going to a dark place. If you hated science in school and you were glad that it was over, this is just a short reprise. When we talk about light particles, the particle theory says that light is a thing, like this thing. But wave theory kind of blew that out of the water. If light was a particle and we had this open slit, then it would hit in all these different places and would hit on a wall. The problem with particle theory is it doesn't explain double slit diffraction, which wave mechanics explains. It doesn't explain shining a flashlight through here and then through two holes here and having areas of light, dark, light, dark, light, dark. That's not explained if light was actually a particle. So when we learned in school, and I'm sure you learned the same thing, we learned particle physics at some point, and then we learned wave mechanics to explain different properties of light. And then it all got unified under quantum theory, which I'm going to go into briefly, and there's a reason why I'm going to go into it. What we're going to talk about now is not really technique, but your mind, your presence. I believe your mind, and Ray and Marie and I, Marie, right? Marie.
No, Mary.
Don't start. Don't start. We had an interesting conversation about pain in your mind and such and so forth, and also with John last night. Your mind, let's start bringing this into the game now. And we never were a set of techniques, but there's you, there's the patient, and there's an interaction between you and the patient. What actually is that? I'm going to try and quantify at least as much as I can one of my mentor's words. I'm going to give you some background material that's really just a mental construct for how we're going to understand how we relate to each other and how opposites relate to each other. We're going to consider how cranial rhythm relates to an energetic model, and how flexion and extension are actually flip sides of the same coin. We're going to consider that our thoughts are an energy and therefore can affect and change, or rather, I like to think of set the stage for an outcome to occur. I prefer to say set the stage for an outcome to occur because it's not my responsibility if you're going to die of cancer. Some people, that's going to be their mission here. So there's you, there's them, there's two different plans, and there's something we're going to try and do together. And at the highest, I think we're going to try and set the stage for them to try and be well. Maybe they will, maybe they won't. Let's talk about energy just for a moment. Energy is palpable. Well, I know this would be an easy sell in this room. Is energy palpable? Yeah, we're all drinking the same Kool-Aid. We all believe that. But let's just step outside of this room and talk to somebody like my mom or my dad. How would I actually explain it to them? This we all know, Einstein's theory of relativity, E equals mc squared. Again, it seems like just a phrase to us, except that phrase has allowed us to do things like blow up Hiroshima and Nagasaki and make microwave popcorn, which is really convenient for us. Okay, so it has uses, both horrible and useful for us. They're extrapolated from this kind of technology, that they're able to do things like this. So if this is somewhat true, or at least true enough to blow up a city or to make popcorn, and we just manipulate it algebraically, what it says is m is equal to E over c squared. What does that actually mean? I'll tell you what it means to me, and actually it doesn't come from my mentor, it's just me thinking about things from not sleeping too much. We would all agree that mass is something we can touch. We can touch the baby, touch the table, okay? But if something touchable is equal to energy over a descriptive term, because that's what c squared is, it's just a descriptive term. So if this is palpable, this must also be palpable. That's what it means to me. Okay, something else to think about. Heisinger's, do you know Schrodinger's cat? You know the experiment of Schrodinger's cat?
Yeah.
I have to be be reminded.
Thank you. Well, you're going to get a reminder anyway. Okay? There's Heisenberg, busy doing Heisenberg things. Not the Heisenberg to be confused with. You know what? I have to update this slide. I just thought of it just now. I have to update this slide for the next time I do it. It'll only work in America though. If I do it like overseas, it'd be like, what? That's the problem with my strange sense of humor. You know, doesn't always translate.
I was curious about that.
Pardon me?
I was curious about how your sense of humor
It mostly does.
translated.
It mostly does, but there's those moments where there's just like you could hear a pin drop, and I'm like, yeah, that didn't work. That didn't go at all the way I thought it might go. But this is the Heisenberg we all don't know and don't love. Okay, we came up with the Heisenberg equation, which actually led to quantum mechanics. Schrodinger's cat was, if we put a cat in a box, and inside that box, we can't see inside the box, there's a bowl of food with poison in it. If the cat eats the poison, the cat's dead. Okay, so the question is, for those of you who don't know the experiment, is the cat dead or alive? For those of you who do know the experiment, please don't spoil the rest of the movie for those who don't. Is the cat dead or alive? Don't know. How can we find out?
Look inside the box.
Look inside the box. Schrodinger says by looking inside the box, we change the experiment. It's not the same experiment. So while the box is closed, the cat is both dead and alive. And the Heisenberg uncertainty principle, which you don't need to know, says that we can know how far an electron is moving in space, or we can know where it's at. Can't know both. In order to know where it's at, we need to stop it. In order to stop it, we're changing it. Because a photon, for us to view a photon to bounce off of an electron, it's so much bigger and stronger than the electron that it's changing its path. Again, making your head explode too early in the morning for this kind of crap, I know. But this stuff is used in our world to make all the modern conveniences that we have. There's a very good book if you're interested in reading, yes.
How does that pertain to energy as palpable?
I'm going to tell you.
Okay.
It doesn't pertain to energy as palpable. We're on another thing. We've left that behind. That's behind.
Limits left.
Yeah. Well.
Stop.
Yeah, stop right there. No, there'll be no snickering. You don't know why we're snickering. Okay, so there's a very interesting book if you are interested in reading some lay physics called In Search of Schrodinger's Cat, written by someone. I forget his name. So, In Search of Schrodinger's Cat. And it's written for a layperson to understand, or physics equations if you want to understand that on both levels. And what you need to know about quantum physics is this. Is quantum physics, which we're using in our world to describe things, says that electrons are spinning around the shell. And that around the shell of a nucleus, we have a pair of electrons. One spins this way, and the other one's spinning that way. Okay, follow me? And we name them different things. And if we separate them at an equal and opposite direction, at an infinite rate of speed, and we change the spin on one, then the spin on the other one must change. What does that say to you, Marissa? You just give up right away. Just give up right away.
They do it instantaneously. They do it simultaneously. There's no time difference.
What it says is that time is not linear. Time is out of the equation. I think it's kind of mind-numbing, really.
Say it again.
If you follow the experiments that are used to create technology and things that we have using quantum mechanics, that if this is the nucleus of whatever atom you want to make it, in that first orbital shell, you have two electrons, one spinning to the right, one spinning to the left. This is what quarks, strange, charmed, all those subatomic particles are. If one's spinning this way and one's spinning the opposite way, that's what has to be in order for our science to work the way we currently understand it. If we separate this is what they're doing in the Hadron Collider that everyone thought was going to cause a dark hole, and suddenly there's no more course, no more Earth, no more nothing. Okay, they're trying to play with this to try and find the Higgs boson. That's what they're trying to do. So if they're going in an equal and opposite direction mathematically, and then if we can change the spin on that one over there, this one must instantaneously and immediately have its spin changed at the same time that one is changing. That these are linked in this way, which means time is out of the equation completely.
I think that, what makes it hard to understand quantum mechanics or quantum physics is that we all instinctively understand or are knowing of Newtonian physics. And in the subatomic world, Newtonian physics does not apply because there's no matter.
Correct.
So.
Newtonian
it's a whole new
physics
set of rules.
and quantum physics come together under string theory, and I'm gonna end before I get to that, because then there will be cranial explosions inside the room. But what I want to get at is that the possibility exists for things that we don't understand. Scientifically, it exists for what we don't understand. These are things they're doing. There's a collider in Japan, there's the Hadron Collider between Switzerland and Italy, and other things. And they're doing these things right now that it kind of opens up the door to the whole science world of space travel and time travel and everything that I'm not suggesting that's possible. What I'm suggesting that's possible is you're touching a patient, and what you're thinking about, it matters. That's all I'm suggesting to you. I'm suggesting to you that who you are matters. And that's important. We never were a set of techniques. We never were a set of just doing a cranial lift. That a cranial lift from Michael or Sarah or Sally is all going to be the same, with the same patient X, Y, and Z. That what you bring to the table, and this is what I got from Fulford directly, your attention and your intention matters. I don't have the responsibility to cure cancer and make all your problems go away. I do have the responsibility to show up, pay attention, and give you everything that I have with my focused attention. And then if my focused attention actually is an energy, then it is something. It's a currency. It's something that can be used. That's all I'm suggesting with quantum mechanics. And I'm giving you this weird scientific background because it's our real world. This is how, we blew up atomic bombs and made terrible things and made popcorn and made MRI machines and made laser beams. It's based on understanding these equations, which is long since been washed out of my brain, except a small little geeky gyrus that's still left. It's got 4 brain cells that are still carrying a flame. Yes?
Isn't it one of the things that they discovered too, that the draw between molecules is stronger than the pull of gravity? That gravity is like negligible in compared to...
I can't answer that question. I'm sure my uncle could, actually.
Like the Lisa gal that is in charge of that project that you were...
I'm sure I can't answer the question. I'm sure I don't know the answer.
Okay.
But there was something very interesting that we thought happened a few years ago, and that was through the Hadron Collider, that a neutrino arrived faster than the speed of light. And then it was found out that they lied. Okay, scientists are just like everybody else. Okay, so if that actually happened, anyway, it's all far beyond me. Yes?
Well, I mean, all this said, this also explains intention. Like where we place our attention is where we place our energy. Where we place our energy,
Absolutely.
the particles arrive. It's the wave collapse theory.
I agree. I agree.
I mean, you just intend inches into the body, but you don't have to press that deep. And you are literally affecting it through
Absolutely.
through this explanation.
1000% agree with you.
Exactly.
What you think matters. On the other hand, what the patient thinks matters. Things we were discussing last night. And then there might be some other force that
What is the saying? What is the saying with Newtonian versus quantum? It's that cause and effect is Newtonian, and quantum is causing an effect.
Okay, I don't know that saying, but it sounds good to me.
Yeah.
You've come up with a few good things here.
Right.
Yeah, they're all going in your file. The ever-expanding Ray file. You're a smart guy, Ray. If this is true, then what we think matters. This is what I got from Fulford, what I got from Elliot. I'm trying to relate as best I can. We're trying to purify our thoughts. And by that I mean your attention, and Fulford always talks about that, your attention matters. Toward this end, the more clearly we understand, the more powerful become our thoughts. Fulford thought that we should be able to study anatomy, physiology, have all that in the engine, in your processor, and then you don't need to think about it during treatment. You just need to be focused on the patient. If your attention matters, so does your intention. We love our patients, but you're not in love with them. It's not in love, sexual love, that kind of thing. But you really should have some sort of compassionate love for your patient. This is a question I personally had interest in when I did the interviews, and I asked people, I said, do you think you need to have, I asked them indirectly, do you think you need to have passion to do what we do? And some great people said yes, and a lot of people said no. So there's all sides of the fence in osteopathy. I think you need to be passionate. We want a good outcome. Your thoughts are energetic, and through energy we hope to put something into the system to achieve a change. Fulford said the highest level of observation is being there with laser-like attention, not drifting and not detached. And it's interesting, because I sat in lectures and heard, I don't deify anybody, but he was a really great man in our profession, Robert Fulford. Someone reduced some of his thoughts into a book called Touch of Life, which you can read his thoughts. Fulford was an osteopath who also had as a mentor Randolph Stone. Randolph Stone was a chiropractor who became an osteopath, wrote the books on polarity therapy, and had an Ayurvedic background, very interesting background. So I sat in lecture and I heard this about being focused on the patient, and other colleagues of mine, we were in that same lecture, I heard them talk later on about that Fulford said we should be detached, and instructing people that when I'm treating somebody, I'm imagining that I'm on a mountain and, you know, I'm an Indian floating around on a mountain. I'm thinking of that, you know, what was that? Either commercial for Fresca or almonds or one of those things. You know, I'm on a mountain and all the snow's coming. What was that commercial for a goodie?
It was Wrigley's gum, wasn't it?
Was it? Okay.
Klondike Bar?
Peppermint
No.
patty.
I can answer that question though. What do I do for Klondike Bar? I'd kill someone for a Klondike Bar. I'd commit murder for a Klondike Bar.
Post a cap on that.
Say, you shouldn't hypnotize me and say, you can't hypnotize me and say do something bad, go around the bank, because I'm out the door before you finish the suggestion. Okay, so anyway, this is what I got from Fulford, and he was my personal inspiration to actually doing this as opposed to going into surgery, whatever kind of crazy thing I had in my mind before medical school. He was the best I've ever, it was something special. So being there with laser-like attention and being completely focused, and that's all I'm doing. In addition to feeling something, what am I doing in that moment? I'm giving all my attention to them. I'm not thinking about anything else. I'm not thinking about my problems, I'm not thinking about their cancer, I'm not thinking about their diagnosis that the other person gave them, I'm not thinking about anything really, just I'm here for you, I'm holding your hand. Let's talk for a moment about structure and function. This sort of dovetails with things that Elliot's interest. If we consider that there's a relationship between structure and function, then we must consider that that function precedes the structure. There must be a need for that structure because of function. We're going to go back to the embryology, where the embryo was totipotential. And this is where a lot of research is being done today with stem cell research. The idea of stem cell, if you're unclear what that is, stem cell is a little child, the one that hasn't become the doctor, lawyer, therapist, whatever, engineer. Okay, they haven't differentiated into something else. And the thinking is, take that cell that has the potentiality of becoming anything and put it in an area where anything is needed, and it can find what needs to happen. We're thinking about this energetically, that things can be totipotential. Personally, I've witnessed both ends of it. People alive that shouldn't be, and people that should be alive that just dropped dead. And I did promise somebody at the end of the day, if you ask me about Bjorn, and I can tell you, we don't have to buzz that one out because he's long under the ground, but I can tell that story, yes.
What is totipotential?
Totipotential means it can become anything. A cell that is totipotential, it is a cell that can become a red blood cell if the body needs it, can become a white blood cell if the body needs it. It has all potential.
I'm just not familiar with the word.
No worries. When I was little, I was totipotential. Now it's over for me. I'm on one road, going downhill really fast. We need to talk just for a moment. We're going to get to playing techniques, don't worry about it. I got to give you all the underground here. Let's talk about the law of motion. The principle of polarity and rhythm are part of the law of motion. Regardless of what form energy takes, its movement in energy is due to a polar relationship. Stillness, at the core of all movement, is no movement. Where there's no movement, this is going to come back to being totipotential. Everything moves, everything vibrates. If we go off into string theory is all based on 10 or 11 superstring theory on how many levels of vibration there are, how many dimensions there are, not just the 3 dimensions we live on, but everything's vibrating at some rate. Wave mechanics shows this. A.T. Still said life was motion. I'm not one of the better ones who can quote him, that's why I need to write it down on a slide for myself, but he said life was motion. Certainly anything that's not moving is not working well, and it's dead. Poles and opposites. The idea of polarity requires that everything has a pair of opposites. They're extremes of the same entity, but vary only in degrees of each other. Hot and cold, they're not different, they are extremes of the same measurement. They only vary by degrees. We could say the same thing about light and the absence of light and calling it dark. Large and small. To understand opposite poles, we have to understand that there exists a neutral core, something that's not dark, that's not light, that's in the middle. Something that's not hot, that's not cold. Between positive and negative, there's neutrality. We can even apply this to emotions. We can take love and hate as two extremes. The middle thing is being indifferent. You really only hate somebody that you really used to love. Or you can even go the other way around with a little bit of alcohol on board. Okay? So, but to be completely indifferent.
That's
It's
true.
gonna change back.
I'm from the alcohol generation. It might be actually the Heisenberg generation now, so I don't know. But that middle spot is to be indifferent, to not care one way or the other. Poles arise from each other, and they cannot exist without each other. You can't talk about hot unless there's a cold. You can't talk about light unless there's a dark. A magnet has two poles, and the relationship is mutable. Okay, it's changeable. Take a magnet that's got the north and south, we cut it in half, we have two new poles that arrive from the halves. They relate to one another, and they cannot one can't exist without the other. Now let's talk about flexion and extension and start to apply this idea to cranial. The idea of flexion only exists if we can talk about flexion and extension. Between flexion and extension, there is neither flexion nor extension. Flexion and extension give rise to internal and external rotation. We're going to start to think that flexion and extension are primary. That our biodynamic theory is that internal and external rotation are a sequela because of the action of flexion and extension. We're experiencing these all as happening at the same time as one cranial pulse, but they are happening primarily because of what happened in flexion and extension. We're going to give you a biodynamic or an embryological model for that. Embryology and micro were my two worst subjects in medical school. And once I was done with it, I said, thank God, I'll never have to do this again. I'll just look up the drugs like everyone else does when I have to give it, and I'll never have to think about embryology again. And then Elliot said, Steve, you really need to understand the embryology. And I went, yeah, okay. So what book would you recommend for me? I really don't. I want him to stop talking to me about it. He said, no, this book you gotta get here. No. Okay. So it's funny, stuff that I said in life you don't want to do. Now I really like it because I find the use of it. Okay. Let's look at the midline and let's consider this to be a primary structure. And I'm going to give you Elliot from Wolford, from Sutherland's reasons why. The part that I'll leave out of this lecture, if you want to read, there's a book, I'm sure you can get it because it's reprinted, called The Biokinetics of Human Differentiation from Blech, Schmidt, and Gasser. Later on in life, Blech, Schmidt, and Gasser, who are anatomists, were introduced to Sutherland, and Sutherland ran away with these ideas, but that's where it came from, Blech, Schmidt, and Gasser. They wrote a few books, but Biokinetics of Human Differentiation.
Was that in the 30s, 40s?
I don't know. I don't know the date of the book. But they had a different way of looking at embryology, about how things... We learned that embryology happens because there's a genetic map, and then that code is followed. And they looked at it through all these different fields, 8 different fields of mechanical forces changing the embryology. And certainly without going too much into it, mechanical forces on embryology are causing things to genetically mutate. And they gave a lot of proofs to this. And I heard several lectures by Gasser, who was teaching at LSU and was still lectured at Art Academy in his middle 80s. So that's 10 years ago. I doubt he's still alive. But anyway, so
He's
these...
listed in the phone book in New Orleans.
Is he?
Yeah.
Okay, well, he was at LSU, and he was sharp as a tack, and he was like in his mid-80s. I want to say 10 years ago is probably when I heard him come to our academy and lecture about this stuff. And, I should be one-tenth as cognizant as he is, really. So Sutherland focused on the midline as primary, but these ideas got merged with these anatomist ideas. He said, other holds can fool you. We're going to do some different holds. And I do these with my patients. I do the ones that are comfortable to me. The nasal septum, sphenoid, occiput are midline, and Sutherland felt that the body acknowledged these as midline and more primary than things that are lateral to that.
Well, I don't understand what that means.
They're midline structures.
Yeah.
And he felt that midline structures were there before the lateral structures were. I'm going to give you the why.
Okay.
The what for is coming right now.
So that makes them more important.
That's what he felt. It made them more, not more important, it made them more primary. It made them first.
Okay.
So if we want to look at you in the most early elemental stage,
Okay.
maybe is a better way to say it. So I'm going to explain to you what was explained to me embryologically. Primitive streak. On about day 15 of development, a faint groove appears along the longitudinal line of the germinal disc. This is the primitive streak. Before that, you're just a zygote. You're a blob. This primitive streak gives rise to the notochord, which we can think of as the neutral core. Okay. Before this streak happens, you have no orientation. You have no up, down, sideways. We don't know where your arms are going to be, where your stomach's going to be. You have no orientation. As soon as this streak appears, we know what's going to be your top, we know what's going to be your bottom. Around day 15. The primitive streak is then going to begin to, cells are going to migrate sideways, and you sort of become two-dimensional in that regard. We know where it's going to be left and what's going to be right. During the primitive streak, there is no anterior, there's not a posterior midline, there's only a midline. The anterior and the posterior midline appear once the embryo starts to fold. Okay? Once that folding happens, we have anterior and posterior. The primitive streak begins the orientation of the body. Begins so we can see where your top is, your bottom is. This midline is a channel with energetic movement that's described by, you people are all TCM people in here, which is thousands of years old. Some of that is based on this idea of thinking. There must be an electromagnetic reason for embryological development of the primitive streak. There must be some genetic code that's being followed. The primitive streak becomes the midline, which is neutral. We're going to consider the neutral being totipotential. So where we're going to start out is trying to act something that is totipotential. If something's totipotential, it means it can become anything. So if you put energy into a system that can become anything, and if the body has the ability to be well, which is what we hope to believe, then you put energy into a body that wants to be well, maybe they get well. That's where we're going with this. This is where energy in the body is stored. This is where energy is potential. Folding and unfolding. Through embryologic folding and unfolding, this gives rise to a posterior midline and an anterior midline. Energy is going to flow up the posterior midline during the flexion phase. There's going to be something different we're going to try and feel. And it flows caudally down the anterior midline in the extension phase. Anatomy develops as a result of this energetic force. This is a theory, okay? It's biodynamic theory. That it's this force that's causing the anatomy to develop, not just the genetic code. The anatomy develops as a result of this force and thus a relationship between form and function. The anterior midline does not exist until the embryo folds and unfolds. At one point, you're just this two-dimensional disc, and the stomach and heart is up here, and then it folds down. When it folds down, then you have this cycling energy through your body. So we're going to try and access a totipotential area. This, I can't give you an explanation, just going to give you words given to me from Fulford and from Elliot. The anterior midline, he believes, to be your energy, your consciousness, and your function. Posterior midline to be your attainment of your spiritual connection with your nature, your God, whatever that means to you. I can tell you where that dovetails from because I know Elliot very well. Because your posterior midline is going to go up to your crown chakra and your anterior midline is going to go into the ground. And my Elliot is very much into grounding patients and doing different types of things like that. Let's talk for a moment about retrograde energy flow. People are ungrounded if energy flows from front to back or if it goes retrorostral, if it goes in the wrong direction. They become ungrounded because they have a positive pole without a negative way to discharge. Therefore, they have accumulated charge without the ability to discharge, which leads to disease. Dr. Fulford would get up in his late 80s and 90s and always talk about this man, Wilhelm Reich, and a book they told us to read called The Function of the Orgasm. Only a 90-year-old man could get up in a crowd of 500 people and talk about buying a book on orgasms. So I did buy the book. I've never read it, but I do have it, so I feel better about myself. But I took his words, and I'm being honest with you. He said I'm a bad liar. Haven't felt the need to read the book. But he gave us this background on Wilhelm Reich. He said that psychology was psychophysiology, and wrote a book called Function of the Orgasm, and said that if an orgasm is not released properly, then energy travels through the diaphragm and causes anxiety. There are so many jokes I can make about that statement, because I don't think a man can have an orgasm that's improperly. But that's all I'll say about it. But certainly this was his feeling, that this was just part and part of the whole energy cycle. This is where we're going to start on the table, at the sacral hiatus. Sacral hiatus is an area where we can palpate dura without bone. Okay, there's only skin, posterior longitudinal ligament, and filum terminale. Mike, you have a sacrum here? All right, throw a sacrum.
There was one.
Yeah, I have it here. You have it with me.
I have one with me too, but it's currently under my pants, so this is yours. Thank you. So this is the sacral hiatus. This is nice. I was expecting like a plastic thing. So this is the sacral hiatus here. So when you put your hands on your, this I frequently do with patients. I'm just not announcing to them what I'm doing. I take my moment to do an observation of the sacral hiatus. I do my sacral release I'm doing, and I bring my hands down, and I stop it where I feel that the bone starts to disappear. Whether I'm actually up here or a little down here, doesn't matter. As soon as I feel that the bony prominence is gone, that's where I'll stop to do this observation. I do it that way from the sacrum because otherwise, if you're going to take a patient and just decide to dig around their butt, okay, for this hole, then they want to know where you're going with this, whether or not you're taking them to dinner later. Okay, from here, everybody's okay with working on the sacrum. They don't really notice the difference of what I'm doing here. This is going to be where the filum terminale attaches to the sacrum. This is where you can touch pia and dura directly. So Elliot makes a big deal about not having the bone between you and the dura and everything else you're feeling. You're more directly on the dura. Personally, just my own little asterisk. I don't see the magic of having the difference between bone and not bone. So I'm still working through genes. I'm still working through everything else. And in an energetic world, I'm doing work that's off the body. So I don't think that we have to be in a particular magical spot. Although we are midline, and there's something different about midline. So what I'm going to do is I'm going to come right off in this spot here, and we're going to palpate dura without the bony obstruction, and we're going to walk through an exercise. Elliot describes this posterior longitudinal ligament as the body's battery. At the sacral hiatus, you can access the body's physical and spiritual reserve, meaning you are a therapist trying to make them well, being still in this moment. You have your energy connecting with their energy and feeling right at this hiatus, which is the remnant of what was their notochord. And if your whole brain is starting to melt from the embryology, between anterior midline and posterior midline, the notochord is what is the remnant of what was the central midline, which would have been neutral. What we're going to try and feel now is, I can only describe it as an electric river. That's my words, not Elliot's. At the hiatus, we're going to experience a quality of something that's flowing past you, and it's dead on midline, and everyone in this room hopefully will be able to feel something. It's directional, and it's electrical in nature. The act of observing changes the thing observed. This goes all the way back to Heisenberg's uncertainty principle. You're part of the experiment. Elliot said another thing that I don't know whether it's actually on the interviews or whether it was after the interviews. Because what we started finding as we were doing the interviews is people told me some real gold after we shut the camera off. So what we started doing was we started just leaving the camera on in the corner. And Elliot is not, he's not an old doddering person. So he started talking about something like, is that camera on? I remember I'm like, oh yeah, we left that on, shut it off. So I don't know whether we used it on the interview or not. Whatever I used, he approved. But what he said to me was, we're trying to materialize the spiritual and spiritualize the material. And I'll go to my grave remembering that. You're touching people, and you are trying to materialize the spiritual. You're trying to bring into their material body something that is a spiritual force, something that's an energetic force. And you are spiritualizing their material aspects. Oh, okay. Elliot Blackman. He's still alive and he's still in practice. It'll cost you $1 gazillion to get treated by him. He don't do no favors for anybody. He's a wonderful guy. When my receptionist really had a problem, I flew her out to California to see him. He's in San Francisco and Union Avenue. Wonderful guy. Anyway, okay, so the active observation will unwind the tissues. That's what I observe. I don't do this technique and say, we're no longer in the realm of do this technique for the low back problem, do this technique because you have cancer, blah, 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 blah. You're doing this for constitutional wellness. You're doing this to activate something that will put energy into their system so that they can be well. A lot of the old people in the profession would say things to me, and it really used to kind of gall me a little bit when I was young and I thought I was smart. A lot of the old people in my profession would say, they have their hands on the head, like Bud Bernardi, if you see that interview, and I go, he's a great guy, he's a nice guy, old guy, kind of a maybe doddering person, teetering on falling off of reality, falling off the turnip truck tomorrow. And Bud would say to me, well, the mechanism's doing the work. And me, just the way that I am, I go, what the hell is that, the mechanism doing? I want you to show me a technique where you're correcting something and doing something. Don't tell me the mechanism is doing the work. It sounds good, but what am I actually doing with a patient? And I felt that way until Bud worked on me. Then I changed my mind. Okay, so something was happening when that old man put his shaking hands on me. Something was happening because of his attention and putting energy into the system. And he also treated my son. I find both ends of it. I found the dynamic people that I felt their life was more in motion, and I felt people that gave me those spiritual things that I was not attuned to, and I said, yeah, I don't get it, until they touched me, or I saw some of their patients. This is where we're going to start. Put your right hand under their sacrum. You're going to start to pull your right hand down so that your middle finger is straight midline. You're looking to put that finger on the sacral hiatus. For me, I'm going to pull my hand down until I suddenly don't feel bone coming at me. As soon as I don't feel that same pressure, I'm going to call that the sacral hiatus. If you find that you came off their sacrum and you go back up, and you come down and go back up, that's called a prostate exam. So, and people generally don't like it, even females that don't have a prostate. So, for the purposes of what we're going to do, you just need to be on midline so that you have your index finger and your ring finger are next to midline. Okay? So if you start from a sacral release, bring your hand down until you just don't feel less pressure on the bone. So you're between coccyx and sacrum. And then relax your hand. Your patient's going to do nothing. Your other hand's going to do nothing. In this space, this is the last remnant of what was the notochord, that central core before the folding, anterior and posterior midline. Energetically, this is a totipotential structure. What we're doing is observation. Observation is active. You're focusing on your hand, not with your eyes, but with your attention. Every feeling that you have in your hand. Your focus on that attention to them activates energy that is usable by their body to make themselves well. This is what some of the old people said to me, the mechanism doing its work, the mechanism correcting itself. Your observation is helping that correction. Focus only on the end pad of your middle finger. Nothing else exists. In that spot, they are going through flexion and extension, and at the same time there's an electrical current, a river that is flowing up posteriorly. During the flexion phase, there should be a surge. That surge should last as long as the cranial rhythm. If you have your hand in a stream, which is what it feels like to me oftentimes, it feels like that stream moves a little faster. That's the flexion phase. The stream has qualities. If it feels like it's slow and wide, Fulford and Elliott would describe this as someone who has a prevailing parasympathetic tone. If that stream feels more narrow and brisk, they would describe it as someone who has a more prevailing sympathetic tone. Now you're going to take your awareness of that area and you're going to obliterate that middle finger, that pad, as though it doesn't even exist, and allow yourself to feel from your ring finger and your pointer finger everything that is around that current. It's not midline, but it's also flowing. There's nothing to do. In between doing sacral releases, diaphragm releases, at some point, this technique I do very frequently. It's a moment for me to stop where I'm not being hassled by the patient and I can be quiet. And a lot of unwinding happens in that moment. Unwinding is healing for the body. Now bring your awareness back to that last pad of your middle finger. Nothing else exists in your hand. You're straight on that midline structure. Posterior longitudinal ligament, which you're close to, which is the last energetic remnant of the notochord. There's nothing physical that happens from your hand. The observation should allow the tissues to unwind and soften around all your fingers. Now you're going to keep your right hand right where it is, and take your left hand and put all three fingers midline, as close as you can to the pubic symphysis. I don't go in areas that are going to make people uncomfortable with what I'm doing. I'm going to take three fingers in a linear fashion, 3 finger pads, and I'm going to try and reach down to the pubic symphysis so that all my fingers are on the anterior midline. Your right hand is going to stay exactly where it is. And relax your arm, relax your shoulder. There's nothing to do. Now you're connecting to this circuit that is flowing up posteriorly during flexion, down anteriorly during extension. You're going to feel different phases in both hands. It's a circuit that you are connecting to. You want your middle finger, if you can be on the pubic symphysis, your ring finger can be on that same midline, your pointer finger on that same midline. Relax your hand, relax your shoulder, make yourself comfortable. You can lean on the patient a little bit as long as it's not uncomfortable for them. Everything is midline. Their body's process is happening and now you're part of it. You're an active observer of what's going on. You're an active observer, and in my opinion, not osteopathic world, just Steve Sannett's opinion, you're a channel. That's the best way you're going to focus. You're going to relax so that energy passes through you into the patient. They know what to do with it. I'm not challenging anyone's spiritual beliefs, whether that energy comes from Allah, nature, Jesus, whatever it is you believe. If you believe it comes from just a human's ability to be well, that's not a conflict at all. That's going to work through you into the patient. Now you're going to take your top hand and move up to the umbilicus. Keep all your fingers in a midline. We're just working along this midline. These are not magical spots, they're just landmarks that we can easily find along this midline. Whatever level of tension you have right now, you need to let it go. The more you let go, the more you're going to feel. The more you're going to feel, the more energy is going to flow from you or through nature, through you, into the patient. Patient will report to you that they feel relaxed, or they'll report to you that they feel nothing, or they may report something emotional. I've had this trigger a lot of somato-emotional things. If something releases, it's something they don't need to hold on to. You're not causing, you're just observing. Take your top hand and move up to the xiphoid process if you can reach it easily. Sacral hiatus, personally I find this a very nice technique to do. I do it, and I do it very briefly. And some of these listening stations, I do what's easy for me to reach. Energy is flowing up during the flexion phase. It's surging down anteriorly during the extension phase. Our theory says that that impulse, that embryological impulse of the primitive streak going up is what initiated flexion. And that echo of your embryology is what we're continuing to feel. And we see this in other areas of human development. We see your embryology echo. We see it in primitive reflexes. We can make I can make a comfortable analogy for visceral rhythm as well. If you can reach up to the sternal notch, you may put your top hand to the sternal notch. If it's too uncomfortable, go where you're comfortable and where the patient's comfortable. Put everything midline. Where you touch is going to be a focal point to put energy into the patient that should spread some softening of tissue. You're going to slowly withdraw your top hand, slowly withdraw your bottom hand. Before you change places, I would like the operator and the patient to give feedback to each other. If you felt something, if you didn't feel something, then you're going to change places. You're going to come underneath their sacrum with your right hand. Start with your hand cupping their sacrum. Then slowly pull your hand down until you don't feel the pressure against your middle finger. You want the middle finger dead on midline. You want your ring finger, your pointer finger on either side of it. So you might want to put your chair a little bit south of the patient so that your hand can be oriented so it's straight. The point at which you don't feel that same pressure in your hand, let's call that the sacral hiatus, junction between the sacrum and the coccyx. When you find that place, what you need to do is to do nothing. You need to find a comfortable position for yourself so that you can sit for a while. Relax your shoulders, relax your elbows. Let your hand relax. There's nothing to push, there's nothing to make happen. What we're touching, what we're close to touching, the posterior longitudinal ligament, energetically, in a three-dimensional world, which we are, is the remnant of what was the notochord, what was that primitive streak, the beginning of the primitive streak before it folded. It is the neutral core. It is the area that can become whatever it needs to become. We're calling it totipotential, meaning that the body can take this energy and use it as it needs to use it. Relax your mind, relax your hand. For me, the best description is feeling like I have my hand in a creek. A little running body of water that's running past your fingers. That body of water has surges in it, has moments where it seems to run faster and moments where it seems to run a little slower. Those moments where it runs faster, these are the moments she is going into flexion. Moments where it runs slower, they're going into extension. And it's going to follow the same cranial rhythm, same slow rhythm. Focus all of your awareness, your inner mind, not your eyeballs, but your inner mind, what you're palpating, on just the pad of your middle finger, the end of your middle finger. Nothing else exists. That river has qualities. If you feel that it is moving slow and wide, Elliot would describe that as a person who has a generalized parasympathetic tone. If it is narrow and fast, he would describe it as someone who has a prevailing sympathetic tone. Now you're going to take your awareness and go away from that middle pad, so that your middle finger does not even exist. Let your awareness go to both sides peripherally. This area is all flowing with this river, not as primary as that midline, but it's still flowing. Relax your shoulders wherever you're at, relax them a little bit more. Relax your neck, relax your hand. There's nothing to create. Bring your awareness back to that central pad, end of the middle finger, and go away from your ring finger and your pointer finger. Bring all of your attention, all of your focus, everything that you can sense and feel to that pad that's in the sacral hiatus. You're feeling this with your mind. The act of observing this area is going to allow that area to unwind and soften around your finger. It'll take the energy through you, through whatever you believe and whatever belief system you have. That energy is without limit. And their body can use that. Now you're going to take your left hand and you're going to put your pad of your middle finger on their pubic symphysis, your ring finger and index finger also on that middle line. All three fingers are going to be in midline on the top. Three fingers together. You got to be together. Relax your hand. Relax soft. Now you're connecting to a circuit that flows up posteriorly during flexion and flows anteriorly during extension. Relax both hands, no tension in your hands, your shoulders. Once their body folded, and the heart and gut folded, they had an anterior and posterior midline. This energetic circuit that was completed has never stopped flowing. That's what we believe, that's what this theory is the flexion and extension, the cranial rhythm. around both hands, tissue should start to unwind and relax. That's a physical manifestation of putting energy into the system. Now your top hand, you're going to drift up to their umbilicus. It's not a magical area. It's just an easy landmark for us to find and identify. You're going to take your top hand, you're going to move up to the xiphoid process. We're just making some different connection points along this anterior midline. You're putting energy in their sacral hiatus and it is flowing down their anterior midline, following their anterior hand. If you can reach, you can move your top hand to the sternal notch. If you can't, you can move your hand a little bit more cephalad. You can take your mind and focus along that posterior midline and travel to their anterior midline. You're not doing, you're not creating, you're not causing. You're observing them. We love them, but we're not in love with them. We love them as another person struggling on the same road we are. You don't need their problems and they do not need yours. So we're observing them. Observation is love. It's the only currency you have. It's the only currency you have when you're not here. It's your ability to love and your ability to receive love. Not an easy process at all. It requires you to let go and realize that you can't cause and you can't create, but you can care and you can let that flow through you. And that's a very wonderful thing. And it's enough. The difficult patients that you face, you are enough. You were enough before you ever came to this class. That's just a realization that you have to be comfortable with. You're enough. You're going to slowly withdraw your top hand. Slowly withdraw your bottom hand. I'd like you to take just a minute or two, tell them what you may have felt. Genetically, they're the same. We start talking about the embryologic model. These things echo throughout life. It's a rhythm that starts, and then we're feeling that echo. In a way, your cardiac rhythm is echoing from the first time it beat, except it's really happening. It beats, something makes that first beat, and then it continues. It echoes. You take your first breath, it echoes. We could apply this also to visceral. The visceral motilities happen to follow the embryologic unfolding of the organs. So here, this resisted the descension, the gut descending. We're going to do a palpation here. It's not a magic. I don't believe in magical spots. Some things are kind of brought up to me as though this is going to happen here and that's going to happen there. I don't really think so. It's just a new feeling that you can feel that maybe you weren't aware of. And when we find new feelings, one, it's cool. So there's that. Okay? And two, it gives us a way to focus on something maybe that we weren't focusing on. It doesn't matter that I do it, I don't do it. I just give you my edits after I give you what my teachers have given me. I like to do this. I find it pleasant. I don't find it uncomfortable for the patient. And I like that zone of play for me. After I've done my work, after I've done the painful stuff, I like to play. It's for me. And the patient's more or less zoned out. So this, the interlateral fontanelle, what is Terion, is where we're going to palpate that ADG. The ADG tense, okay, tense with extension, and it broadens with flexion. The way you're going to find this is this. You're going to bring take your fingers and feel this little crack on your eyeball on the side that you thought was just you. By the way, it's everybody. Okay, that's where your frontal bone is, meaning your zygoma. We're going to start a palpation there. From here, what you should feel fascially, and you're going to feel bony-wise, what are you feeling here? What's the motion here? From the frontal bone, anyway. It's going to be flexion and extension. You're going to walk back until you get about 1.5 centimeters or so, and if you have to follow the rhythm. This is not just a bony thing. You're going to walk back, and at some point, you're not going to feel the flexion extension. You're going to feel cephalad caudad. When you feel that cephalad caudad, you're in the spot where the ADG is, and I'm going to walk you through a visualization with that. The visualization, yeah, that's what I'm going to do. Visualization can be a little spacey, but these are little conversations that you're going to have in your own head when you're with the patient. They're not out loud conversations I'm having with the patient. You certainly may if you want. But when you're holding this, you're holding everything that's it. When you're touching them, period. If I was well enough in life, a big enough saint, which is not going to happen in this lifetime, I think maybe we could touch them and maybe they'd get better. But lacking that capability, we touch them in different places in their body with different theories, approach them from a position of, and Paul and I had an interesting Taoist versus Thevist position on love and what that all means at lunch. And what we learned is that I love lunch. I love lunch. I love lunch a lot, and I love dessert. It's the best part of lunch. So I'm just going to give you my own inflection on it, which is I do love my patients. I love 98% of them. 2% I wish would stop following me. And so I had to run away from them, and I'm in Thailand. They can't follow me anymore. But you have to be able to love. It's easy to love the person you're attracted to, that's a nice person, it's pleasant to you, brings you pies at Christmas. It's hard to love the dirty, disgusting person with smelly, stinky feet. And for the most part, I'm okay with it. And I really feel that feeling for some people that are really down in life. How do you turn it on or turn it off? I don't know. It's what you bring to the table. And also Ray and I were discussing this. It's you. It's always been you. There's some value. If you don't think that you're a part of this equation, you still are going to bring value. You still can be a technician and you'll do something. You showed up to the big game. It still matters. But it's going to matter more if you realize that you are the tool, and this tool is changeable, and how that tool feels makes a difference. So I have colleagues that would say, no, be detached, and they're very upstanding people and they get their treatments. You're going to hear this lecture from me. I'm not detached in that sense. And without going too far into it, Paul and I had this discussion. He said, you must be, I don't want to paraphrase you incorrectly. He said, if I really cared that I had a good outcome, then I must also really feel bad or something that I don't have the good outcome. What did you say?
Something along the way.
Something along those lines.
One pole without the other. You can't really have.
That's what he said. That's what he said. And I do have one pole without the other. Because I do feel good if I get a good result, and I wish for them a good result, and I don't feel too bad when I don't get the result. I look at it as, okay, it didn't work. I don't get invested in it. What I'll say is, me personally, the work sustains me. The work that I do in poor countries, that's where I really feel free. When I'm not actually getting paid, I just go and do what I can do. I feel free, and it sustains me. Friends that I know that are very excellent, and I'll leave their names off so that he doesn't have to do more work for HIPAA violations, taking names off the thing. Some friends that are excellent. They work on somebody and they're so invested in the outcome, and they're excellent treaters, by the way. But if the outcome's bad, they get sick, they get ill, they feel bad. I never had that. I never had that. If I feel bad, it's because you're a bad person and you've said something bad to me, not because I worked on you and I felt married to the outcome. Anyway, so we're going to do this exercise here, and I'm going to walk you through this, and I do this with my patients. When you have their ADG, you have everything that's in between it. And there's moments where I feel that John asked me, are you feeling that this river is going this way and you're feeling those words that you gave us? And I said, sometimes I feel that way. But I feel I'm in the river. I just don't know if I can use the words always that Elliot gave me. Wide and fast, slow and tight. But I feel that I'm in the river. I feel I'm connected to the patient. And we discuss some other common feelings that we have. When I'm doing this, you're holding everything that surrounds that. If you want to turn your awareness to their sella turcica and to different bones and to the pituitary gland, you can do it. But whether you do it or not, the moment you're thinking about swimming around in their anatomy, I can't do that, but I want to be able to do it one day. The moment you're swimming around in their anatomy, you're connected to them. And that is the benefit. That's the pill right there. I believe it. The chair will now recognize Pat Cassidy.
Some of us are still having trouble with the sacral hold because, I feel my own heartbeat a lot when I'm doing that, and I feel my hand getting crushed sometimes. And so I was talking to somebody at lunch who said she puts her hand in from the side, but then maybe that's not okay because it's not really on the midline.
It's okay with me. Probably not with some of my teachers. I think you're touching them. Let's step away from all this material for a moment. You have some intention to really help him. I think it makes a difference from that moment forward. From that moment forward. If you don't give a rat's ass about him and you're waiting to see whether or not your car's getting repaired right or not for getting your snow tires put on, I think it makes a difference no matter where you put your hand. So that's what I believe, whatever you want to do with that. So there's that. No one's going to take that away from Pat Cassidy. No one's going to give that to Pat Cassidy. Now, having said that, I try to do what was shown to give to me in a way that's comfortable for me. If you put your hand in such a way that it's uncomfortable for you, this is not working. How are you going to be in the moment if it's the same moment where your hand's getting crushed? You can't. So you can try to turn them on their side, do it that way, put them prone, play any way at all. But it has to work for Pat has to be comfortable first.
What about slightly?
Go ahead. My answer is always going to be go ahead. And I had plenty of teachers that said no, must be here. And then, longer story that we don't have time for. At one point, from one of my mentors, I broke free. Okay, and I said, I'm not listening to you anymore. And the moment where I said I'm not listening to you anymore, it was actually quite a tragic, emotional reason why that all happened. So I'm done listening to you. Do my own thing. Drop dead. It was stronger than that, by the way. Okay, get me drunk and I'll tell you. Get me really drunk and I'll tell you. So I said, I'm done. I'm not your student anymore. And I found out that a lot of things you have a lot of freedom. Intention is so powerful, but you got to realize who you are. You're a drop of water in an ocean, right? That's all you are, is a drop of water in the ocean. Isn't that sad, Doreen? You're just a drop of water in the ocean. I mean, it's a big ocean, right? But the ocean would miss you if you were gone. That's what I realized. All I am is a speck, but that speck counts, and it can count a lot. And a speck doesn't have to follow rules, but my speck cares. I really care, and I really love most of my patients most of the time. I'm into it. That's what I bring to the table. Try to follow rules. I try to understand the embryology. What if it's all crap? We were just talking about this. What if none of this model is true at all? What if the model is only so that you can believe it and then say, Steve said it's true, so it must be true, so I'm free to work now. So I'm free to express myself energetically. I'm no longer encumbered because he said that if I do this, they're going to get well. So there. So let's do this model here. What I want you to do is one person get on the table. Let me demonstrate up here. I'm going to be right here at this table. This is what's going to happen during extension, during flexion. Just follow. John, would you lay down, please? Okay, so you're going to start. Use whatever fingers you want. It doesn't matter to me. You don't have to dig out that bony prominence in him. We all know where the greater wing is going to be. Greater wing of the sphenoid. That's where pterion is. Start a little bit anterior to that and just relax your hand as much as you can. Okay, I'm just using my middle finger. Okay, from here, if I just relax and tune everything out, it's flexion, extension is what I'm aware of. What I was taught, what I'm aware of is that something is moving forward. I don't want to say it's moving down to his feet, but it's moving somewhere between his feet and that pipe up there. And it's the same flexion extension that we've been taught to feel. And then if I'm going to move back just a little bit, and I'm still feeling that flexion, extension, pull. If I move back just a scooch more, now I feel, now he's pulling up. That's tenting during extension, and now it's getting broader during flexion. The moment where I'm feeling this up-down sensation is telling me that I'm in that area underneath this coronal suture, where there's 2 sheets of dura that are going up underneath, and we're going to do a walkthrough with what's under your hand.
When you
Yes.
say pull back, are you meaning pull away from him or pull posterior?
Flexion,
You said,
flexion extension. We learned it as going down to the feet, but essentially there's going to be this forward motion. When you're on that dural girdle is, can't do it with my hands. It's tenting. It's coming up, and then it's going wide. Okay, because during extension, during flexion, this is going to be going narrower, and then during extension, it's going that way. So the moment where you don't feel an anterior-posterior pull, but you feel an up-down pull, then you have the dural girdle, the anterior dural girdle between your fingers, between 2 fingers.
And as you're looking for that, you're going posterior.
Yes.
That's
From that crooked spot on your eyeball. Okay, so John, you can stay right here. And somebody's going to be partners with John. Everybody on the table? Everyone should be on the table?
Oh, who wants to work with me?
Hello, good.
Mike, let's get everybody on the table.
Sorry.
We didn't have a partner?
I need a partner.
Sean? You find a partner? Okay.
We're good. Let's move this way.
You're right.
Let's move this.
Yeah, maybe.
I'm just going to move the table a little bit so that
Try a chocolate chip. It's a thin waffle.
Waffle
Just a thin waffle. One more waffle.
I'll have a lot.
What was his name? Mr. Creosote.
Oh, Jesus.
Creosote is that nasty stuff on the telephone pole. Waffle in.
It's all waffle.
I
thought you were my wife.
I buy dark chocolate in my house because it's safe.
Yeah. My kids will eat anything.
Our daughter won't touch,
Nothing
won't go near it.
Nothing safe.
Okay, everybody on the table?
I looked at my,
Everyone on the table? I want you to start at this spot. Rather than dig around their eyeballs, you can let them dig around their own eyeball and start your fingers there. At that, I don't know if there's a name for the suture between the frontal bone and the zygoma. Okay, start the suture with just 1 fingertip on each side. I don't care what fingertip you use. We need a partner down here for Doreen. Doreen?
She's in the bathroom.
Okay. Now, just for a moment, I want you to stay at that spot, and you should be able to feel an anterior-posterior movement. That's what you're going to feel anterior-posterior movement. Now you're going to walk back just a few millimeters with that finger, whichever finger you're using. You're going, when I say back, you're going posterior into the table. You're just before the pterion. You're not in the greater wing of the sphenoid. Just move back. You should still feel anterior, posterior movement. Mike, can you help? Now you're going to walk back a few more millimeters. Now you're going to walk back until you feel that movement is no longer anterior, posterior. You're going to feel either a downward pull or an upward pull. And it's quite dramatic. If you're able to feel the rhythm, you've been able to follow what we've been doing, this will not be it will not be difficult at all. There's going to be an up, down pull, a cephalad, caudad pull. When you find that spot, you're going to stay there. Part of what happened during development is the face got longer, the gut and heart began to descend, and that was resisted in part, not in total, but in part by this dural pull. You should be about 1.5 centimeters or so back from that spot, that first spot where you started. Now we're not creating, we're not doing. You're going to take your awareness, just like you're holding a bed sheet at two ends. Those two ends, if you start to take your awareness from the ends of your fingers and move inward, you will be moving inward along the coronal suture, along the lesser wing of the sphenoid. You can bring that feeling somewhere to the middle of that sheet, which is going to go around the sella turcica. The sella turcica is what houses the pituitary gland, the infundibulum. Bringing your awareness there creates some relaxation in the sheet. I believe, and others believe. You don't have to believe, you just have to follow with your awareness. What you may feel is a greater amplitude in the cranial feeling, cranial rhythm. You can go from this observation post to going on to moving other bones. This is a way to get inside their head, not just around the bones and around the articular surfaces. Bring your attention from the lesser wing of the sphenoid inside the skull. Sweep around the anterior clinoid processes. This is what's in front of the pituitary gland. Your hands should have no tension in them whatsoever. Your shoulders need to drop. Your neck needs to relax. Let your awareness sweep out to your fingertips. Become aware of a downward pull, which is the flexion phase. Bones are going into flexion when you're feeling that downward pull. When it's coming up, bones are going into extension. These are all happening at the same time. Creating a little bit of freedom in that sheet allows their entire cranial mechanism to move better. It allows their entire cranial mechanism to go through a larger amplitude. If they're able to go through a larger amplitude, we're going to call that vitality. There's a potency that resides in us that has the ability to be well, has the ability to find wellness, has the ability to move on bad emotions that are stuck, bad feelings, things that they have held on to for years, without verbalizing. Reduction of stress allows them to feel freer. Whether or not they're going to move forward and move on, that never was your responsibility. Not osteopathy, but Steve Sennett, personal feeling. If you want to put a creator, an energy, a nature, a God, or whatever you want to ascribe to what we're doing, I believe that all that can be asked of me by nature, God, any of the above, is to show up to the game and to care. And I do. I'm going to show up and I'm going to do the best that I can, and I'm going to love the patient, and that's all I can do. Once I've done that, I feel pretty good about it. What the patient's going to do with that energy, I do hope that they will do something good. The more you can relax your hands, the more you can relax your shoulders, the more you will focus on the energy between your fingertips. Now you're going to slowly withdraw. Slowly withdraw. Before you change places, I want you to, if you felt something, I would like you to just tell them briefly, less than a minute, what you may have felt or what they may have felt from you, and then change places on the table. You can have your partner can show you where that line is, that crevice between their eyeball, between frontal bone and zygoma. And you're going to put a finger, doesn't matter which finger pad you use, I don't care, but do the same on both hands. I'm using my middle finger, doesn't matter, ring finger, whatever you want to use. You're going to be on both sides. What you want to feel is that anterior, posterior pull. That's what you should be feeling. This is a bony feeling. Anterior, posterior.
You stay on the crack and go more posterior.
Well, you've already moved off the crack.
You're off the crack in which direction?
Which finger are you using?
Both.
Yeah, you're off the crack, I think. But just move a little bit posterior off the crack, for lack of better terminology.
Say no to crack.
Just say no.
Say yes to crack.
You should still be feeling that anterior, posterior motion. Now you're going to drift a little farther back, which will probably be somewhere between 1 centimeter and 1.5 centimeters, thereabouts. When you're in that depression, that is the greater wing of the sphenoid. Somewhere around there, you're going to feel the first pull that is going down to the feet, or pulling straight up to the vertex. Then you're in the place for palpation of what we're calling the anterior dural girdle. Girdle being something that holds something up, and what it's holding up is resisting the development of the face, and the gut. Once you've reached that spot, you're going to stay there. That pull is going to be down to the feet during flexion, and it's going to be up back towards your chest during extension. We are under the coronal suture. We are at both ends of what is across the jugulum, the greater wing, the lesser wing of the sphenoid. However, your hands are relaxed, they need to relax more. You need to let go more. There should be no tension in your hands, no tension in your wrists. Shoulders need to drop. Find a comfortable posture for your head and neck. Now if you're following that drag down to the feet and pull back up to your head, you're going to take your awareness from between your two fingertips and you're going to start to move inside the middle of that sheet. That sheet is going to cruise directly along the greater wing, the lesser wing of the sphenoid. It's going to go on the anterior part of it and on the posterior part. If we go posteriorly with your awareness, you're in the middle of the skull. That sheet is contiguous with dura that's going to go around the infundibulum from which hangs the pituitary gland off of the anterior clinoid processes. You don't need to know the anatomy, you just need to know what's between your fingertips. That anatomy is a bed sheet. It's a bed sheet that changes with your attention put on it. Your focus, and I will just add my own comment, your compassionate love, put something into the system that the system may choose to use or they may choose not to use. You are observing with them. Your observation connects them to some sort of power grid that's bigger than you, I, this room. They have the ability to change, they have the ability to spontaneously heal from whatever problem. You benefit as an operator from being part of that solution. You're not connected to their sickness, you're connected to the part that wishes to be well. Let your awareness come back to your fingertips. You're at two ends of a bed sheet. You're going to follow them going down to the feet and let that sheet relax a little bit. Follow them coming back up to the vertex. Give them a little bit more space. Start to withdraw your mind and then slowly withdraw your fingers. It can take about a minute. Tell them what you may have felt. They can tell you what they may have felt, and then we're gonna talk some more. One comment. I said bed sheet. Probably a bad word. I think you're a little bit more complicated than a bed sheet.
No. Some of us.
But you have this grip on the tissue. I don't know what you'll be able to see from here. You have this grip on this tissue. You have dural duplication where you have the sutures. You have dural duplication over bony prominences. When I say it's not it sounds complex to say dural duplication. Two sheets of dura. You have two sheets of dura which leave a space. What's in the space?
Fluid.
What kind of fluid?
No.
You have sheets of dura, they open up, they leave a space. What do we call that space? Venous sinuses. What's in venous sinuses? Blood. Okay? The anatomy, one thing that made anatomy simpler for me is when I started putting cranial together with things that sort of make sense to me. Talk about dural duplication by itself doesn't make sense. Talk about the falx cerebri doesn't make sense. Trying to memorize all the venous sciences like we had medical school was a lot of just straight memorization, not a pattern to it. But if somebody does cranial, there's a pattern to it. Wherever that dura is duplicated and then it opens and folds, where it opens and folds is going to be a space. Not a vein, because it's not contractile in the way that a vein is contractile and doesn't have valves. Doesn't have valves. Doesn't have smooth muscle, but I don't want to say that it's not contractile because fascia has contractile properties, but not the same. So anyway, you're grabbing this duplication. This duplicated dura here is what resisted the gut as you began to develop and get longer. That's what we're palpating.
Can I just ask the folds? What is that?
radiologically?
The fold, we're just talking about, you have sheets of dura, there's two sheets running together, and at some point they open up and it becomes a space where blood's draining out of the skull. That's what the anatomy is. The importance of it, we can just start touching all different parts of the skull and talk about what we're feeling. And just taking your awareness to something else that you can feel. You can feel this pull, this fascial pull, as opposed to talking about bony movement. Is it more special than anything else? I don't think so. Some other people may say yes. I don't think so. I don't believe in special places in the body. I believe your whole body's special. Whole body's sacred. Yes.
Folds are like, Dora is like a sheet, it's just a wrinkle.
Picture two sheets the bed sheets that are running together, and there's a pipeline going through the middle of it. That's what is your dural sinuses. Had they explained that to me in medical school, or actually explained anything to me in medical school, I might have gotten that. But it was like, memorize this, memorize that, point at this structure, point at that. Medical school is not about learning osteopathy. Osteopathic medical school is not about learning osteopathy. It's learning about anatomy the same way every MDs learn anatomy. Point and name it. But as I see it now with the cranial model of something that's living and dynamic and everything moving together, the picture starts to make sense. There isn't anything in the body that doesn't make sense. There's just things that we don't understand yet. I think Carl Sagan, or no, not Carl Sagan. Who's the old-time Isaac Asimov? Was he a science fiction writer? Is that the guy I'm thinking?
Yeah.
I think he said, somebody will know, he said magic is just science we don't understand yet. Something like that.
Yeah.
I kind of think that.
It's on Seinfeld.
But I do believe in magic too, so.
Yeah.
There's another.
The one I like is magic. Magic is when you don't know how it works.
Yeah, but I still believe in magic. You're not going to get me on that one. I want to be
Well,
Gandalf one day.
Yeah.
Or Sauron. I can go either way.
That's because he knows how it works.
Gandalf or Sauron. I can go either way. Heisenberg. Okay, let's move on with this. We got a lot more stuff to do. And only a little bit of time. Primary cranial motion. The frontonasal embryologic origin is different and different function, therefore they have different vertical sutures. This is straight from Fulford, Elliott. I'm not sure whether Sutherland had the same importance on it, but they treat this frontonasal complex as something that's more important because it's a midline structure, has vertical sutures. It's not coronal and it's not lateral. We're going to put our middle finger in the suboccipital area, and I do this hold once in a while. It's going to be uncomfortable on the table. It's not uncomfortable if you have pillows with your patient. If you have pillows, your hand goes under the pillow and you can do whatever you want with it. If you're on this table and you're going to do this hold, many of you right now are going to tell me it's uncomfortable because you're trying to manage the balance on their head. So we're going to do this with left middle finger in the suboccipit and right, second, third, fourth fingers on the metopic suture. It's just another way to hold and take in just the anterior information, the anterior posterior information without, the flexion extension without talking about rotation. Energy is coming up posteriorly and going down during the extension phase. So it's going to look like this. We're just doing a hand hold and we're going to feel cranial rhythm. And if you've had some difficulty with feeling cranial rhythm, if you try to stay just midline, I think you'll feel that the rhythm feels much bigger. It's not that it got much bigger, it's just that you're going to be much more aware of it without taking in all the information of the entire skull. So I'm going to put a hand here right along the Indian. I'm going to run 3 fingers along the metopic
Show the back
suture.
again, show the back again.
I'm going to show it on the table. So,
Would it work if you had the person lying sideways?
pardon me?
The person's lying laterally.
No reason why you couldn't. I'm just going
I
to do
just
it.
meant with your hand underneath, it would be more uncomfortable like this. That was one that they laid on.
It's not for me because I use pillows. I put a pillow.
I meant here.
Huh?
I meant here.
To whatever floats your boat.
Thank you, kind sir.
I think you'll be able to try it this way. You got a big hand, you'll be able to do it. Put your hand this way. Okay, this is a good way to feel primary cranial motion, meaning we're just going to focus on exactly what's on the midline. Okay, there we go. So. This is going to be under her inion, my middle finger. The rest of my fingers are just supporting her. This really shouldn't be too uncomfortable for anybody in this room, but you do have to hold her head like this. And here, if I come here, this is a very relaxed position for me. Here you're feeling just flexion and extension, not taking in any other information. I think If you've had any trouble with feeling the rhythm, you will not have trouble here. You can take this as an observation, or you can take her and try and increase what it is you're feeling. When she goes into flexion, the back of her head is going back, the frontal bone is going forward, but actually the frontal bone is going forward, the metopic suture is falling inwards. So just go right along this metopic suture. We're just going to do a palpation for a moment.
And when Steve was
We do
talking
the
about
next part.
keeping your arms rested, you see where his arms are? They're always on the table.
Arms are always on the table.
People aren't sliding down far enough on the table so you can rest your arms. That's an important part because if your hands are stiff, you're not going to get the feedback.
Some of you are I see the head right up here hanging off the table, so you're doing way more work than I am. I'm a big fan of doing no work. Let me just go forward another slide or two. Okay, no. We've got another intraoral thing. Let's do this first. Okay. Come here. If you're straight on that metopic suture, that's going to collapse in as the ethmoid goes out. That's what you're going to feel in these 3 fingers. And the bottom hand, I'm going to relax and just feel that middle finger along the ilion. The next 2 fingers are just supporting. If you want, maybe you put coat or something under their head, make it a little easier for you. Okay, let's move on to some mobility techniques now. Doesn't require you to feel the rhythm at all. I do this once in a while. The longest lever. Maxilla and vomer can be accessed and used as the longest lever that you can put on the SBS. This is something that comes from Dr. Sutherland and Elliot via Fulford said that he didn't like teaching these techniques too much because he felt that people would be too aggressive and get into trouble. The idea of lever is a mechanical principle. So a lever is what you use. Well, actually, you don't use it anymore. The tire irons are these little things that go like this. But it used to be back in the days when you went like this. Of course, in the 1970s. Huh?
Now you just do this.
Yeah, hey, fix my car. So a long lever is when you're far away from something, the mechanical work you're doing on this end has a lot of effect on the structure that's down here. So we're going to be very far away from the SBS, and so he felt that if you were going to be too rough, this may be profound. Evaluate and treat with a finger. This is the instructions here. The directions are the picture says it all. So I'm going to grab underneath that premaxilla. I'm not going to pull their teeth, not pulling anybody's teeth, but I'm going to grab the premaxilla. One finger up under the frenulum, thumb up underneath the premaxilla, and you're going to use this as a wedge. And you're going to feel, this is a really funky thing to feel. Who are you doing this to? You're doing it when you feel the SBS isn't moving, you've done your other cranial techniques, you feel like they got a stone head, and you need to pull out something bigger. This is a nice thing to do. This is much nicer than the thing we did yesterday, grabbing underneath that bottom part of the sphenoid and pulling forward. But this is a really funny feeling because you're going to grab them and wiggle, and it feels like you're going to pull a jigsaw puzzle piece of their face is going to come off. Ooh. That's my sensation of it. But so far, no one's face has actually come off. So we're good. But if you're going to leverage their teeth, that might be a bad idea. So don't do that. Okay? And this is not with rhythm. And I'm not staying in here to palpate rhythm. When I put a glove on, I'm doing something that's uncomfortable, do it. Go away. I'm always doing a frontal lift. If I got an extra hand, that's what I'm going to do. I want to show you this, and let me just roll through an alternate.
Talk about this.
This is why we're saying it's a long lever. Here's what I'm wanting to affect, and that's as far away as I can be from it affected. In HVLA and manipulation or adjustment, when we talk about long levers, we say a short lever technique is doing something to C3 to mobilize C3. A long lever technique is turning the OA to mobilize something further away like C3. So mechanically, this is a long lever. That's what's meant. Here's an alternate. This is much easier. I don't do this too much. Oddly enough, I do the other one more than I do this. People don't like you grabbing their nose. Okay? As soon as you put a finger under the booger hole, people get a little weird. And I also don't like doing it. And I'm not going to put on a glove to go under somebody's nose. So people just like to get creepy. But this is also a long lever technique. It's not as long, but you can use the nasal septum. Elliot has a, I don't know what the right word is, proclivity for doing things to the nasal septum. He says because everyone ignores it. The nasal septum, it's gone by the time you look at a bony cadaver. The nasal septum's not there, so it doesn't mean anything. But it is a midline structure, and it's contiguous with the ethmoid, perpendicular plate of the ethmoid and the vomer. So we can use the nasal septum, actually, a cartilage technique. Go right here at nasion, here. This is what's happening during flexion, and just force a little bit of motion. You can feel motion here quite easily, and you can also take them through motion. Okay, so let's start with first one here. Don't need a glove. We'll need a member of the studio audience. Need our lucky glass of water.
Which table would you like me to recline
Right
on,
there.
sir?
Right, this one right here.
Thank you.
Need a glass of water? You definitely need the water for this. I got to go up under the frenulum and through the rectum.
Partner?
See, now listen to me.
You're done.
I'm dim away.
Yeah, John, you failed the hearing test. Just want to let you know. Rectum. Nearly killed him. Thank you. You're the only one who thinks this is funny.
I thought you were going to use a really long lever.
That's from vaudeville.
That's just for me a softball. I'm just really resisting now saying something.
Okay, John.
I was at surgical rotation. The surgeon loved to say that. He'd say, rectum, nearly killed him. And I thought it was funny, and I've used that joke 1,000 times, and everyone stares at me like deer in the headlights, except
Well,
for my brother
the
John.
joke. You know the joke, right? That's the punchline.
No, I don't know a punchline to the joke.
Oh, okay. Well, I'll have to-
You'll share it with me
I'll
at some
have to-
time.
have to bring it up.
When I was on surgery rotation, the surgeon used to bust my chops all the time. Then I wanted to do manipulation. I may have told you. And he'd always put his hand around some old lady that was a patient. He'd go, Santa, you know what I did for her? If I told you this, just stop me. I won't tell it again.
No.
He goes, Santa, you know what I did for her? And I'm, you're an intern, you're nobody. You're a doctor, nobody. You know what I did for her? I don't know, Dr. McGowan, what do you know? I saved her life. Saving lives, Santa, not cracking backs. Bust my chops all day long. Then, once a month or 2 times a month in the hospital, surgeons, they get the worst back neck ever.
Right.
That's when it was, when I'm not on service, he goes, hey, that's when it changed from Santa to Steve. That was an upgrade. Steve, you got a minute to look at me? Sure, I got a minute to look at you. I always treat him. When he's done busting my chops, he'd say, I think you're a good man. I'm just kidding you. And I said, I think you're a good man. We'll just go back and forth. He sent me a lot of patients. I never took people's insults for what we do, body work. If they think what we do isn't important, they don't see the value in it. I take the insults with a grain of sand, a grain of salt, nothing. I don't answer it. The day when they asked me to help them, their family, their kids, my door's wide open. I skipped my lunch, I stayed late, I came early, and I've been over backwards, and I make more friends that way. The ones who really are going to go to their grave thinking what we do is useless, why waste your breath? Why waste your breath trying to prove to them what we do works? We need to get one of their family members on the table. Yeah, I said it. Okay, now. Okay, so.
You want a chair?
No, I'm good. I can hold them this way. I can do a frontal lift. You have choices here. You're going to open. I'm going to go up underneath this frenulum here. I'm going to go here. Now, it's not going to hurt at all, but it's going to be a funky feeling. I am forcing it through flexion and extension. You can hold it a little bit, or you can just start to rock it. Funky?
No.
Okay.
Thanks.
Yes, it was funky.
After my big build-up. Okay?
That was it?
Yeah, that was it.
Well,
Or
I felt funkier.
should have gone with the rectal thing.
Come too late.
Give me that glove back. Wipe it off.
So this is like all.
You can very easy to follow flexion and extension here, and take them a little bit further into extension, take them a little bit further into flexion.
Do you have a coccyx lever you can use?
Pardon me?
Do you have a coccyx lever you can use?
Oh, there's all kinds of levers we can use. All right, let me have someone else. Let me have another person.
That may have a more profound effect.
Yeah, I'm trying. You know, what can I do? Open. Close. Close. Relax. From an operator standpoint, I can feel right between her pterions, between my fingers as I'm doing this. And it feels like if I wiggle just a little bit harder, this is coming out. But it's not.
And your finger's touching her teeth? Your bottom finger? Or no? Are you still
Well,
trying
not
to clear it?
not intentionally, but it might be, but
Okay.
not intentionally. How's that?
I kind of like it.
Me too. Okay. Hold on. You can take her through. You can force her into flexion and extension, or you can follow the rhythm and just take a little bit further. Do it as mobility or do it as motility. Either one. Very easy to feel the rhythm. Very easy to feel the movement. And here you're using the septal cartilage, essentially. Indirectly ethmoid and vomer, but essentially septal cartilage.
And you're accessing SBJ at this point.
S-E-J?
SB.
Yes, trying to.
SBS.
Trying to access junction, symphysis, same thing. Okay?
All right,
I mean,
different on each person.
I don't have to think about what it may feel like to you, but it will cause something to happen. That's what I want. I want something to happen.
Those are here.
I'm not really feeling it that much.
I feel it. You'll feel it when you do it to whoever you're doing it to.
Okay.
So, yeah, quite a feeling actually.
See, what he helped me.
Fiction?
We have the sandwich in it. Here.
I thought you had something.
I do.
Oh, okay.
This is where you want to.
Extension. I can't bend over that far.
It's much lighter than I would have expected you to do it.
Yeah.
Much lighter.
All right, let's talk for a moment about embryological seams. This is the last part of the work that I did of this course with, I think this is mostly Elliott, probably not Sutherland. I don't know, it's really part of the cranial work, but I'm going to put it here. During development, the embryo goes through a series of folding and unfolding, which gives rise to branchial arches. These pouches here, these swellings. These swellings are then going to turn into stuff, okay, maxilla and mandibular swellings. If we take a closer look, this is going to become maxilla, this is going to become mandible, and this is the head. These branchial arches become pharyngeal arches. These colors here just show you where these early cells are and where they migrated to. This is not the diagram that you look at for the dermatomes. You know, the somites come together and then they migrate and different cells go in different directions. So it's just giving you a clue of where these arches are and then the different structures, the different cartilage structures, what they become. This is showing you from the same areas where these first and second arches migrate to different areas of the face to become muscular structures. And this is another map showing you the cranial nerves, where they're beginning all from the same arches and then ending up in different places. What we're going to try and get in contact with, or just identify, is this seam. And I'm going to give you the explanation verbatim the way it was given to me, because I can't make any kind of sense out of it. And I do them not too much, because it's a little uncomfortable, and you'll see why. I'm not uncomfortable pain-wise. The positioning doesn't really work for me and my hands. This is Paul at week 5, okay, when he was just a little tiny, young Paul Ryan, okay. You know, my father said if medicine doesn't work out for me, I got a career as stand-up. But I think I'd be afraid. I think I would get it and I would just freeze up. But my day job? Yeah.
The thing is,
Thanks for that endorsement page. Yeah.
I'll take that as a compliment.
When I'm in the car alone and it's really loud, I sound remarkably like Frank Sinatra. Another calling I thought I had, but not going to happen. So at week 5, you have these different placodes that are going to become what will become the frontal nasal complex, the nasal placode, maxilla, mandibular swellings. Early week 6, this starts looking less like a tadpole and more like something like the alien from one of those movies. By around week 7, we can see what's going to become this filtering between this process here, what's going to become the mandible. By around week 10, now we recognize it as a human face.
Where's the rest of the body?
It doesn't have a rest of the body. It stops here. So what we're going to try and feel are these seams where areas came together, going all the way back to these arches. When they had these original folds, these seams where it was one structure and another structure. There's nothing to do with the seams. It is a straight out observation. And we're going to look at a few different observations. Energetically, these seams or remnants of these foldings can be accessed. Accessed means observance. Okay, we're going to try and touch them and activate the body's innate healing. Activation, and I had to extract these words from Elliot. Activating the body's innate healing means you're touching them, you're thinking about the seam, you're trying to feel where structures come together, and the fact that you're doing that on them and you're able to feel something is putting energy into the system. Energy into the system means energy that their body can do something hopefully positive with. That's what these words mean. This activation occurs by acute observation. Acute observation, again, sat in a room with Fulford and at the American Academy of Osteopathy, which would be about 500 people in that room. He talked about observation, about being there, laser-like attention. These are all words he used. And then other colleagues who sat in the same lecture said, no, what he really meant was to be detached and off on a space cadet mountain somewhere having a fresca. Don't think that's what he meant. So Elliot was a student of Fulford's. I was not a student of Fulford's. I heard some lectures from him, but he said, no. He said, acute observation. You're there, you're in the moment. All of Steve Sant is thinking about what I'm palpating, what's between my fingers. In the absence of dysfunction, these seams should be seamless. So I'm going to do this with you. I'm telling you I don't do it with patients, and you'll see why when I show you the hand position, because it's too difficult for me, and the only thing I become mostly aware of is my own hands being uncomfortable. But sometimes I can, when I'm teaching this and doing it, maybe I feel something, maybe I don't. This is an addendum to what you're doing. If you're doing something that is difficult for you, painful for you, you're probably not going to do it with patients. You're probably not going to get benefit. If you can feel something, great. First branchial arch between the mandible and the maxilla. Observation will cause the body to reorient. Pressure will cause the body to reorient around the tissue. Same way as we did the sacral hiatus. I don't think it's a magical place. And if you're feeling pressure in your hand, Pat said that was crushing her hand, I'd say pull your hand a little bit more caught at until you don't feel that it's crushing your hand. And maybe you're on the coccyx, maybe you're on the hiatus, and maybe you get some benefit there. Try it that way. But if we stop and we have a slight observation there for 10, 20, 30 seconds, and you feel some tissue softening, take that as a benefit. That's the benefit that they got. If they got something deeper from that, hats off, great. I don't have a way to evaluate that. It's a tiny part of your whole treatment. Okay, it's not the treatment, it's just a tiny part. So here what we're going to do is do an observation. I'm going to put these two together here. Here's why I don't do it, okay? My wrists don't bend that far. And in order for me to put my hands across their face this way, my hand's immediately uncomfortable. This is not a physical thing that you're trying to feel along some sort of bony structure, like feeling in between intercostal spaces where you can say, I am in this space. You're in this energetic space that has now become a face that doesn't have that line. Okay? So there's an energetic line here back when you were young Paul Ryan, little tadpole. Okay? Now that you're beautiful old Paul Ryan, okay? He's got a face, a mandible, and all kinds of stuff. But there's an energetic line. Okay, there's an energetic line here.
You're going to get that a lot in India, by the way.
Oh, yeah. Yeah, this is southern India. Northern doesn't do it. One of the guys I got loaded with was in Bangalore while we were at the bar doing the Budweiser I Love You Man thing. I said, Nirav, you don't do this. And he said, no, I'm from the north. That's only these people down here. So what do you know? So this is the first branchial arch between maxilla and mandible. So I put my hands here, put them together, and I'm trying to identify if there's a bed sheet that has come together. Does it feel like two different sheets coming together? Does it feel like one thing? Do I feel like I'm crazy? Okay, so I don't spend a lot of time because I'm sure I'm crazy. Okay, if you feel something and you observe it, maybe you feel some unwinding. That's what we're going for, unwinding. If I go a little further, oops, second branchial arch is between mandible and hyoid. Hyoid is tucked up under here. I watch people do hyoid techniques all the time by trying to grab the thyroid cartilage. Okay, that's not your hyoid. Your hyoid, for most of us, is tucked up under. So it's the same thing. Do not confuse palpation of the seam with palpation of the physical stuff. So this is where I'm going to be close to finding that hyoid. Okay, so let me have somebody lay down here, head here.
Have you tried to do it bilaterally?
Well, no, because I need, if I'm going to find the seam, I need to have a hand on each side of the seam. I could go bilaterally by giving her a face mask, but she might be unhappy with that. Okay, so I want to go between mandible and maxilla. So I'm going to do that by coming across. But this is already uncomfortable. It's already uncomfortable on my wrists doing
I've seen
this.
this sideline with the head resting on you.
Then that would be a better way to do it. That would be a better way to do it. So any way at all that you want to do this, but I want to have my fingers together here, and I'm just trying to identify if this is a sheet of clothing coming together. I want to find the area where they come together. And I'm going to observe it, and if I feel some unwinding, great. I feel something, but I feel mostly my wrists bending back. So this is the first seam. Let's turn it this way. Okay, and this is the second seam between mandible and hyoid. Hyoid is tucked up underneath. Okay.
Doing the first seam in that position as well.
This is the way I was shown to do it. John's got it's definitely a better idea, doing it.
Lay on your right side.
Come.
Lay on your right side. Face that way.
Show me what you're doing.
The other way. You go to the right side.
Would you do both sides?
Definitely a better idea. So, however you're going to make yourself comfortable, okay, the idea is going between mandible, maxilla, maxilla, mandible, mandible, hyoid. If you feel something, make yourself comfortable. John looks very comfortable, okay, and see if you can feel something. We're going to do this and 2 more seams. Thank you, John. There's a seam at S2. Again, I'm going to just quote for you my teacher's words. The seam at S2 represents what was the caudal eminence of the notochord, and therefore the only surviving totipotential structure, so you can access energy here. The treatment is innate, meaning it's observation. You don't follow, but you observe the embryological seam. Quote from Elliot Blackman: often S2 to S3 is compressed. Before you ask me, isn't it all compressed? Isn't it all one bone? Yes, but this is like an energetic compression. He's telling me about feeling difficult, feeling rough. If it's compressed, when the seam is in dysfunction. If the seam's not in dysfunction, it should be seamless. Okay, that's S2. Again, I'm going to put my hands under. If there's another way to do it, put your hands in a different way. Do it any way at all that you want. I can do this without being uncomfortable on my hands. Some of you probably will be uncomfortable because you're going to have the full weight of their sacrum on your hands coming crossways this way. That's S2, and the last one will be at the seam at the 12th rib. This is involved in the folding of the pleuroperitoneal membrane. Again, accessing the seam is just a matter of fine discrimination of palpation. It's an energetic palpation. We're not palpating the physical structures between the rib cages or the intercostal membranes. Okay? So, come across here. Once in a while this occurs to me to stick my hands across here, but not very often.
Well, L1, 12, T12?
L1, T12, but it is going to be wherever you feel that there's something. That's your brain on drugs.
Woo!
Just say no. Okay, so.
Would you run your hands ever over the spine and just feel where that is? And
I haven't, you may.
Okay.
I'm no different than anybody else. I'm a creature of habit. I do things that are easy for me that I've been doing for a while. Yes?
You go to the shop as well, but I have to go back and forth.
It's already 4:03.
I need quiet because I can't hear.
It's already 2:45.
Yeah.
So do you want to just do the shoppers as well, and then we can only move to the table once, or do you want to do it?
Okay, I'm easy.
Because some people have to leave it.
Okay, I'm easy. Let's do it now. Sarah, why don't you lay down right here? Lay down here, this table right here. Head here.
Head which way?
Head here. Otherwise it'll disturb my whole feng shui that I gotta go. This is just a collage of whatever I've learned from different people. So I'm gonna show you what I do, and then I'll explain what I do. Let's find a place where you can put your hands like that and relax. Okay? All right? Nothing too exciting or too weird is gonna happen. So just relax. Just gonna be very light touch.
It was very different levels of warmth, and then a real stuckness in here. It was very, very stubborn. And then something stubborn, really stuck. And then as this started to circulate, and this went next, then it was able to connect all the way through. That opened up like all crumbs circulating.
Okay.
That's what it felt like. I don't know what.
Okay, that's good, that's good. I'll just tell you what it feels like for me anyway. I really like doing this. Believe it or not, I do this often enough. I just don't do it if people are going to be staring at me, because I don't want to have the crazy discussion. And most people, if they're gorked out, I do what I want, and this is how I end. With babies, I'm not doing it at all. So it's just a collage of things I've read myself, some mentors, everybody give me different direction. And I started doing this in my rebellious phase, which, by the way, hasn't ended. So I just said, I learned all these different things about all the chakras that many of you know far more than I know about it. And what I know is I'm not touching her first chakra. Probably relatives will object to that. I'm sure she's going to object to that. So I'm not going anywhere crazy that's going to cause a problem. I want to work on 2, 3, 4, and I'm not going to touch anywhere on her breast. I'm just going to go right along the sternum when I can. 5, I don't really want to wake her up, so I don't spend too much around the throat. 6, I'm very comfortable with, sometimes 7. So I want to keep her partly asleep. The energetic field that we didn't talk about, there's this thing that you're going to palpate around 8 to 10 centimeters off the body. Baral does this, Barbara Brennan does this, and it's been existing as long as people have been on the planet as far as these different energetic fields. I'm very comfortable working around 8 centimeters. I'm very comfortable working around 20 centimeters. Some different things that I feel. So what I do is I start with a place that's reasonably safe, non-threatening. I'm going to start around 2 and 3. And I don't have to be exactly wherever I'm going to be. I've tried to correlate this more with different neural plexus, and it doesn't really correlate. It doesn't correlate. So I put my hand on something that feels like I'm on the center of something. Whether I'm right or wrong, or it's my imagination, I feel that. And you see my hiney do the little hiney wiggle? And I start feeling like there's an engine moving here. Then if I can get in sync with, it's the hiney wiggle. Okay. So I feel like I'm in sync with the engine.
She's just checking out your wiggle, man. Don't worry about it.
But we're just going to stop there. So at some point, I want to go from here. I want to just put my hand, and I want her to know, because I know she's still watching what I'm doing, that I'm not going to touch her inappropriately. And I'm going to go somewhere close to her 6th chakra. And I want to feel the center of this engine. At some point, I feel it moving, and I want to move, but I'm not ready to take off yet. I don't have any of the words for this, so it's just going to come out the way it comes out. I keep moving back and forth and touching. And at some point I get ready to come just a little bit off the body. And for me it feels like it has a certain spin to it, that if I can be at the same speed, at the same, like if there's a little handle on it, if I can grab that handle and take it a little bit further, that's what I want to do. And then I'll come back down and I'll try and do that same thing here. And I'll come back here. I'll come back here, I'll come back here. Those 4 areas I'm very comfortable working. And then I will constantly keep coming back and saying, what am I feeling here? At the end of it, I want this tissue to loosen and lighten up. And mostly what I feel most of the time, and it was easy to do with Sarah, not all the time, but most of the time, when I'm done, this is what I want. Come over the 3rd chakra, start spinning, 2 hands together, feel like I'm getting the engine really moving. Whatever magical thing I'm telling myself I feel it. Feeling the love, and I come down, and then I'm going to come off so lightly that she's not sure I'm gone yet. And almost every time they will go, their chest just comes up with me. They take that big breath, and I follow it as slowly. I try and stay in that moment where I'm off, but I'm not off. And then I might go down, check her feet, do whatever, and then that's when I would go over and write my notes. And then if I wake them up, if it's a few minutes later, even the people who are not into energy at all, they're like, I still feel you at my feet or my hands or my head or whatever. I don't know if it's that technique or just the whole thing you're weaving together. Because when you're working energetically with them in this close space and you're loving this person, and that's me, okay? So, it's not, I have osteopaths who are going to side with me and those who are going to side against with me. I love 98% of my patients. That guy drove me crazy. I tried to love him, but he was really tough. So I really care for Sarah in an appropriate way, that whatever's going on in her life, I want it to be better. And the discussion I had with Paul, we have some slight differences of our Eastern opinions. Mine's not an Eastern opinion, it's a Steve opinion. I care, and I'm going to do everything I can do for her, short of giving her my spiritual energy, because I just don't have that much. And I'll say this, since I'm unscripted, whatever your belief in, whether it's energy, God, or none of it, and it's nature and it's inherent healing of the body, none of it matters to me. Whatever it is, I think we would all agree in this room, the body has the ability to heal. If you have a faith background, you believe that all healing comes from God, that's good. I believe it comes from not Steve Sennett, because I'm just not that much. And I'm not tired at the end of treating people. I'm not tired, I'm not sad.
Is there a waste component here?
A what?
It felt like you were also ditching stuff. As well as warmth and adding, like I could feel really far away. When you're really far away, I could still feel your energy coming in. But there were moments where it was like you were pushing it out.
I would love to tell you.
Curious if you know.
I'm going to answer you. I'm going to answer you right now. I'd love to just jump into all those articulations and say, yes, I did that for you. What I feel in the moment is something that's just working through me, and we can get more crazy. And again, this will happen at the bar. Whatever's working, it's working right through me because I don't have that kind of energy. I do not have that kind of energy, and I treat patients 6:30 in the morning till 9 o'clock at night. When I was in my regular practice up until 2 years ago, and I was not tired from working. I was tired from being depressed the way everyone else is, from going through life's troubles, and everybody's got them. Everybody's got a different road, right? But not from treating patients. I get something from it. You want to think that I'm doing this because it's a one-way thing. I'm going to treat her, she's going to pay me, I'm going to get this. No, I'm going to treat her, and I'm going to get to be stronger. That's what I get. The stuff that I do in the third world, I think I was talking with Paige, or I was talking with somebody about that. I want to say that I'm doing it for people in Ethiopia. I'm trying to arrange it, but I'm doing it for Steve Sanet because I'm going to feel so much better when I do it. Something sustains me, and if it's God, nature, whatever name you want to put on it, whatever it is, I feel stronger when I'm loving her, and I am. And I have no problem saying that word, loving appropriately. That's working through me. She gets something, and if there's crap that's got to go, it goes. And my crap, she doesn't need it. So whatever she's got, it's enough. And whatever I got, it's enough. So things move out of people, and something sustains me being in that field. And I'll end it with this last piece from Elliot Blackman. He said, "You're trying to do this for people. It's not that you're a better person. You know, we like to think we're all spiritually advanced. I hate that word. I hate that whole phrase, to be spiritually advanced. You know, you're a person just like anybody else. Maybe we're at different spots in the road. Maybe we understand different things. But you've chosen to decide to try and help people with their problems. You're trying to create, by any account, a healing field. By any account, a field in which healing would occur. Would you agree? If you don't, there's the door. Okay? So we're trying to create a field in which some healing will occur for whatever reason it is. Whether it's nature, God, again, I'm not trying to go against anyone's beliefs. But you're in that field that you're trying to create. So I think you benefit from it. And let's say it's all bull. Let's say none of it's true. There is no energy. There is no spirit helping us. There's nothing like that. You're just trying to do a good thing for another person, and there's nothing wrong with that. I think you benefit from the act of trying to be kind. And we do it. Or we try to, when it's convenient for us. For us, it happens to be a job. It's a great job. Trying to be kind to people and making a living at it. So there.
So should we try?
You did gesturally flick something away.
I don't know what I did.
Oh, you did. Oh, he did. Okay.
There was a gestural thing. Your eyes
Okay,
were
cool.
closed. So
Okay. Truly,
something that was.
Okay.
Yeah.
Truly, I don't know. I mean, once I start doing it, I'm in my own little zone. I close my eyes only because I don't want to have 40 eyes looking at me, whatever they're doing. So for me, and now I'm alone. Now the room's crowded, and now I'm alone. So I close my eyes. You can't see me. I'm never alone because the voice is in my head. But for the moment, I'm alone. So if you want to try this, try these seams. Try that.